discussions can go on forever.
Yeah.
Shall we start?
Dr. Saeed Akhtar from Pakistan, and good morning to everybody from UK.
Thank you very much.
Very welcome.
Shall I just start?
Yes, I think it's better to start.
And I have put you in the co-host as well. So please, I think you can let people admit in when they are coming in as well.
All right.
So obviously, if I'm distracted during conversation. So good morning, everyone, and good afternoon, everyone in Pakistan and some of our colleagues from Africa as well. Thank you very much, everyone, for joining in at such a short notice, and especially on a Saturday morning. This is really, really appreciable. And along with my fellow panelist, Dr. Asim Chaudhry, consultant in Bedford, Professor Mumtaz Ahmed, who is a professor of urology and president of Pakistan Association of Urological Surgeons. And along with all my fellow speakers, would like to really welcome you to this webinar on renal cell cancer. This is essentially, as you would have seen on the flyer, collaboration that we have just started to develop between the Royal College of Physicians and Surgeons of Glasgow and Pakistan Association of Urological Surgeons, with the aim to just promote these educational activities, whether it is in the form of webinars or courses, and whenever time allows, any hands-on workshop, with the aim of promoting education among both parties, learning from each other's experiences. And hopefully, after the success of this, we can have a few more webinars like that in the rest of the year. And a few technicalities I would just mention, which I'm sure everybody's getting used to Zoom over the last 3 months, that clearly when the speaker is on, all of us will try to mute ourselves just to prevent any background noise. And but for discussion, clearly we will unmute those who are involved in the presentations and anyone else who wish to contribute. We are already seeing lots of experienced and very, very senior colleagues from both UK and Pakistan. And if there are any issues, please just feel free to ask, and I'm sure we can help each other online. Another thing I just want to mention, that there are 100 participants in this. It's just because it's all organized at a very short notice. So if we see the attendance is a lot more, then we can always make arrangements in the future for more participants. And this one is getting recorded as well. So hopefully we can distribute that as well from iCloud. And this is the program. I mean, my presentation speakers are here who are all very experienced and senior colleagues in their respective specialities, which I will introduce as we go through. And this is the program which I'm sure you would have seen has covered most of the day-to-day clinical topics. It's just about updating our knowledge and what is the most current practice in that. So this is all I've got to say at this point. And I would just request Professor Mumtaz at this point just to introduce to us about PAUS, about his own journey, how he sees the evolution of development of urology further in Pakistan in years to come, and how he thinks this collaboration can help global urology, not just Pakistan and UK, but as I've mentioned, you would have seen a few colleagues from Africa where I've been involved in some work. They are joining us as well. So please, Professor Mumtaz, if you could please say a few words.
Bismillahirrahmanirrahim. Assalamu alaikum and good afternoon to all the faculty, participants, colleagues and friends in Pakistan and abroad. And I would like to welcome them all on behalf of the Pakistan Association of Urological Surgeons. It's a matter of great honor for us to collaborate with Royal College of Surgeons of Glasgow and other prestigious organizations of UK to arrange this webinar on a very important topic of renal cell carcinoma. Pakistan Association of Urological Surgeons is always very keen and would extend its full cooperation to promote education, research and training to its members by arranging these activities in the future as well. And finally, we pray for the health and the safety of all the participants and their families during this difficult time of COVID-19 for all of us. And thank you for all participants once again.
Thank you very much, Professor Mumtaz. Asim, is there anything you would like to add regarding the meeting? Or...
I think this is just a start. We would like to, have furthermore meetings. We have already arranged some meetings. We are already doing on the umbrella of even SARC, Association of Urological Surgeons, and few other organizations. And we are happy and honored to have cooperation with the Royal College of Surgeons of Glasgow and other organizations to have more webinar on different topics of urology.
Great. Thank you very much. Thanks a lot. All right. So fine. So we'll start with our presentations now, our speakers. The very first talk of the day is on management of localized disease. That's how we will start. And on that, the first topic will be on active surveillance, and our resident in Nine Wells Hospital, Dundee, who is on East of Scotland rotation, Alan Johnston is with us, who is going to speak about active surveillance for small renal masses. So Alan, please, if you could start.
And you see the screen okay? Yes.
We can see you. I don't think screen is shared at the moment.
All right. I'll just,
Yeah.
Better?
Yes, it's on now.
Okay.
I think you can.
Okay. Happy enough. Okay, so hello everyone. Thank you for this opportunity to discuss active surveillance in small renal masses. Thank you to the team at the Royal College in Glasgow and PAUS for putting on this webinar. And I hope you're all remaining well during these unprecedented times. So over the next 10 to 15 minutes, I hope to discuss active surveillance in small renal masses. Basically, who is it aimed at, what we already know about the growth kinetics and small renal masses, and what the future may hold for small renal masses and active surveillance. So what do we already know? Well, we know that small renal masses are defined as less than 4 centimeters in greatest diameter. They account for a high proportion of new renal cell cancers, and the majority are asymptomatic, and a high proportion of them can be benign. With the increasing use of cross-sectional imaging in medicine, we're seeing a higher incidence of small renal masses. We know that tumours less than 4 centimetres have a lower metastatic potential when compared to those higher. So what are the management options for a small renal mass? Well, essentially what we want to do is reduce the number of patients progressing to radical nephrectomy. This spares nephrons and ultimately can improve their quality of life and their overall health outcomes. The options for kidney sparing or nephron sparing treatments are either partial nephrectomy or ablation techniques. What I'd like to discuss is active surveillance and who would benefit from this, and the option for crossing over to partial nephrectomy or ablation techniques. So patient selection. Historically, SRMs and active surveillance are aimed at the elderly, the comorbids, and those with a life expectancy less than 5 years. What we already know about age outcomes in RCCs, well, Brian Lane and his team initially looked at small renal masses defined as less than 7 centimetres. They looked at over 500 patients, and they found that despite intervention, whether that be nephron sparing, radical nephrectomy or active surveillance, there was no significant difference in mortality and cancer-specific survival in the over 75 age group. They also looked at the subtypes of mortality in each of these groups, and as you can see, the majority of these patients died of cardiovascular disease and not from their cancer. This was echoed by Alexander Kutikov from Fox Chase Medical Center in America, which looked at overall survival of renal cancer in a patient cohort of over 30,000 patients using the SEEP database. As you can see, as the older the patient is, this looked at every form of RCC and every grade and stage, but as the patient got older, age was an independent factor in survival. They also looked at the cause of death in all RCCs, and it was shown that it was more likely that patients would die from an alternate cause or another cancer. The alternate cause was majority cardiovascular related, and as we know, decreasing renal function is directly linked to cardiovascular disease and cardiovascular mortality. Moving on from this, Kutikov then looked at the competing risk theories. He looked at the Charlson criteria of morbidity. The Charlson criteria of morbidity is scoring patients' comorbidities based on how severe they are and how they affect their life. Basically, what we want to look at in this slide is as the tumour gets bigger, going down the way, there is an increased chance of patients dying from their RCC. However, moving from left to right, we look at their Charlson comorbidities. So the red area in the graph is directly related to RCC deaths, and the blue area is related to deaths from other cause. So essentially what we can see is there is competing risk between patients' comorbidities and the tumour characteristics. So on one hand, we have to assess the patient's ability to recover from surgery, their ability to deal with any intervention, and their own need for nephrons to be spared versus how aggressive the tumour is going to be and how that's going to affect their overall survival. Sorry, just having a bit of issue with the computer. So since 1995 and Bosniak, we assessed the outcomes for SRMs. Traditionally, this was mainly surgery, but active surveillance studies were carried out. And what I'll do is I'll just assess a few of these papers and come up with what we know. So the first paper I'd like to highlight is by Mark Smaldone, and this was a retrospective pooled analysis of 18 series. So this looked at 880 patients, of which 636 small renal masses. Initially, in this individual data, we looked at how many progressed to metastatic disease. And as you can see, out of 880 patients, only 18 progressed to metastatic disease, which is less than 2% chance of that. The second aspect of this study was looking at 6 studies which provided both patient and tumour-specific details. This showed that the majority of the tumours were small. They were small growing, and 65 of these 284 SRMs did not grow at all, and each one of these did not develop metastatic disease. Those that clinically progressed, so either grew to more than 4 centimetres or had an annual growth rate of over 0.5 centimetres a year, were linked to increased age at diagnosis, increased initial tumour size at diagnosis, and an increased growth rate. So that's retrospective analysis. Moving on from that, a consortium of Canadian institutes looked at prospective analysis of growth kinetics. What makes an SRM grow? Is there anything linked to patient or tumour characteristics that make growth rates increase? So the initial paper looked at 84 masses, and the important thing to recognise here is this is T1A and T1B tumours, so less than 7 centimetres. And from this paper, what the team recognised was that tumour size at diagnosis of greater than 2.5 centimetres was linked to increased progression of that tumour to a clinically significant disease that needed intervention. And the one patient that developed metastatic disease in this 84 patient cohort was a large tumour with rapid growth initially. A second paper coming out of the same cohort looked at more tumours and of smaller size. And essentially it showed that the smaller the tumour, the growth rate was slower. There was no specific link between either patient or tumour characteristics that linked to growth. And moving on from the first paper, the maximum diameter at diagnosis was not predictor of growth. One of the biggest papers to come out of this cohort was from Michael Jewett himself. And as you can see on the graphs on the right-hand side, this is looking at biopsy-proven SRMs in the same cohort. So looking at 74 SRMs that had a biopsy-proven diagnosis. As you can see in the top graph, the majority of these tumours didn't show any specific growth pattern. So some got smaller, some remained the same, and some got bigger. They suggested that clinical progression was growing to greater than 4 centimetres or developing metastatic disease. and 25 patients developed local progression and 2 metastatic disease. And a histological diagnosis showed that the majority of these were proven to be RCCs, so those that grew to over 4 centimeters or grew quicker than at the doubling time there. So, now looking at specifically growth rates, when the 72 patients biopsied between malignant and benign disease, there was no significant difference between the growth rates in either. So what we can take from that is that looking at growth rate alone may not necessarily tell us what's going on with the tumour. However, overall, what the team feel is that tumours greater than 4 centimetres or those growing at a rate of greater than 0.5 centimetres per year do require delayed intervention. So Philip Pierozzo out of Johns Hopkins is looking at one of the biggest delayed intervention and surveillance outcomes. They recently published their 5- and 7-year outcomes. So this is basically looking at assessing if active surveillance is less or is as good as primary intervention. So overall, 615 patients were enrolled in the study with an essentially equal split between primary intervention and active surveillance. There was a crossover of about 14% to delayed intervention in the active surveillance group, and the active surveillance group were overall older, more comorbid, and more likely to have multiple SRMs. Reassuringly though, this study showed that the all-cause mortality in the first 2 years was not greatly different. However, it did start to drop off thereafter, and this is because the active surveillance group are more likely to have significant comorbidities. However, the cancer-specific survival was essentially equal in both the primary intervention and active surveillance. However, at about 7 years, over 50% of the active surveillance group had progressed to clinically significant disease, so growing to greater than 4 centimetres or at a rate of greater than 0.5 centimetres per year. What's not necessarily been assessed is this affects quality of life in patients. A recent prospective study of 100 patients on active surveillance showed that there was a poor overall quality of life and a higher level of distress in patients on active surveillance with no biopsy to disease. What does this mean? Well, it means that there may be a crossover of patients wanting unnecessary treatment because they're unsure about their diagnosis, and it may be an area where we can target in the future and highlights the importance of initial consultation on putting patients into an active surveillance cohort. It's already been shown that on prostate cancers on watchful waiting, it's important to assess the patient's quality of life and give them a sort of realistic outlook on what comes ahead. So what does this mean? Does active surveillance beneficial for patients? Well, yes, it's been recognised by multiple guidelines. However, looking at delayed intervention, only one specific guideline suggests that delayed intervention has a trigger, and the trigger is really based on the studies that I've suggested earlier. Ultimately, this comes down to cost effectiveness as well, and for hospitals, study has shown that active surveillance with delayed intervention is the most cost effective means for patients in the elderly population. So when do we cross over to delayed intervention? Well, I think this is a mix between patient and tumour characteristics. So obviously the patient, if they develop symptoms, can be offered ablation or operative intervention. Or if they would prefer some form of intervention, if they're anxious about their diagnosis, if they would rather have a biopsy and possible delayed intervention, I think that's reasonable. What we know from the studies and the growth kinetics is tumours getting to over 4 centimetres have a higher metastatic potential, and those growing quicker have a higher chance of developing to clinically significant disease. Is active surveillance an option for a young patient? Well, I think at the moment, probably not. I think from the outcomes that we've already seen, there is a chance of 1 to 2% in a 40 or 50-year-old patient developing metastatic disease. There's also outcomes at 7 years that suggest 4% will develop to clinically significant cancer. And this basically goes against the theory that we're trying to save nephrons. So I think, yes, there may be an option in the future, but I think there needs to be more robust systems in place. So currently what we know is it's an option for the elderly or the comorbid patients or those with limited life expectancy. What does the future hold? Well, we need, I think, more use of biomarkers and imaging. So biomarkers could give us information about histological subtypes, how aggressive the tumour is going to be, and how likely it is going to progress to clinically significant RCC. Imaging, there's already been studies looking at the use of PMSA, PET scans for RCC, and also using radionucleotide scans to distinguish between benign disease and cancer. So to summarise, it's a reasonable option for patients that are older, have a limited life expectancy or significant comorbidities. There's further need for prognostic indicators, imaging and biomarkers. The growth rate can relate to increased rate of progression, and there is a small chance of metastatic disease. Overall, it's unlikely for a patient that is on active surveillance to develop to a tumour that is not amenable to kidney sparing intervention, by that either being ablation or partial nephrectomy. It requires an involved consultation and substantial follow-up programme at the start, and an involved programme from in the future with regards to delayed intervention and dealing with patient expectations. And the only other thing to add is this something that's needed in the future? Do we need to biopsy patients that are maybe younger, have not significant comorbidities, but would rather go down the active surveillance route? Okay. Thank you.
Great. Thank you very much, Alan, for such an evidence-rich presentation. Thank you so much. Any comments from my senior colleagues on that regarding what could be an ideal patient for an active surveillance? People might need to unmute themselves, please.
Yeah, a brilliant presentation. Just a point of you make, prior to carrying out active surveillance, do you think we should be biopsying most patients before giving them the option of active surveillance? Or can that be based on current imaging modalities that we have?
I think if I just answer along with Alan's, that I think probably in a youngish patient age group, that could be a group where I would biopsy, which just gives an extra peace of mind. Because if the biopsy prove it cancer, then clearly the option opens up whether they just want to have upfront treatment. Because a patient in their 40s or 50s, probably they are going to need treatment, if not now, then 5 to 7 years later. And the only risk we are giving them is upgrading of the tumor or upstaging to a T3A from a small 2 to 3 centimeter lump if we leave it. So probably that's a group where I would probably consider biopsy. I don't know what my other colleagues would think.
Yeah, I mean, the question is, you're not going to upstage it by biopsy. You're going to get either the grade or the histological type. The issue that mainly concerns on radiological imaging is that is this a possible T3A, but then that's a different issue altogether.
Yeah.
I think the concern usually now with the PAUS partial nephrectomy audit data suggests that certainly overall tumors under 2.5 to 3 centimeters, large majority of them are benign to begin with, 30 to 40%. Mm-hmm. And now that the kidney cancer is being centralized in bigger centers, high volume centers, then it becomes incumbent that, if you're treating, let's say 100 patients and 20% are benign, you're probably getting out unnecessary treatments. And overall, the biopsy has become much safer and acceptable with the renal cancer, renal mass biopsies. So the trend currently is that biopsy more frequently, and in fact, the policy certainly in our high volume center, the Royal Free, is to biopsy all small renal masses under 4 centimeters. And that's because of the high volume work that you do. The purpose is to try and cut down unnecessary treatments, particularly like metanephric adenomas, oncocytomas, and things like that. And part of the work that has been shown that carrying out nephrectomies or partial nephrectomies for oncocytoma does carry morbidity as well. And the data also suggests from PAUS that there is a degree of mortality there as well. So certainly in high volume centers, prior to embarking on active surveillance, we on the side of biopsy if feasible. I take note of the elderly. Yeah.
Yeah, thank you very much.
Yeah. This is Dr. Saeed Akhtar from Pakistan. Alan, excellent presentation and really a good food for thought. See, I think since a lot of audience are from Pakistan, India, and Africa, I think we also need to put another perspective to it, and that is that you know, a lot of people will not follow up here. So you know, when you are selecting your patients, I think it is extremely important that you know which patient is going to be compliant with the follow-up.
Yep.
One of the most important thing in any active surveillance protocol is that you understand the mind of the patient, the maybe financial status of the patient, especially in the countries where there's no insurance system, or there are financial obligation towards surgery, etc., etc. So I think, and then as Faz was saying, you know, if person has a Furman 2 grade versus Furman 4 grade, you know, that changes my thinking process. So biopsy maybe in patients who are, you know, I'm thinking that who are in a reasonable good shape, I at least want to know what kind of histological grade. Until such time we have more important genetic markers, which will tell us. Right now, our knowledge of biology of the disease is very primitive in renal cell carcinoma, I must say that. So we have to actually develop tools which will actually guide us towards more advanced markers, which will give us some confidence that we are dealing with not such a malignant disease. Thank you.
Great. Any other comments, please?
Zishan, this is Pradeep Bose here. I just got a question for Mr. Faz Mumtaz, if I may. If the biopsy is negative, Mr. Mumtaz, do you discharge the patient, or do you still follow the patient up or ask the referring institution to follow them up? In other words, is the negative predictive value of the biopsy good enough for us to say, well, this is benign, we don't need to run a scan on this patient?
So that's a brilliant question. Yeah, I think if the biopsy is conclusively benign, then, for example, for an oncocytoma, we do repeat one more scan in 6 months to a year. But if it's overly benign, then we discharge the patients. The consensus is not yet clear. We've just started a survey, a PAUS survey, to see what is the general perception nationally currently. But there are no clear guidelines as such for a negative biopsy, how to monitor small linear masses currently. But I think it was definitively proven benign, and with confidence, then yeah, one more scan to look at the trend. Now, of course, there's a lot of, the reason why we also currently follow in a high volume center is to see and understand the natural history of these benign masses as well. And I take your point, a negative biopsy is not 100% negative. You have a hybrid tumors as well. So we are of the consensus currently to monitor for a short period, for 6 months to a year, unless they are part of our trials. We have currently started a NEST trial looking at comparing partial nephrectomy versus cryoablation. And within the trial, we have a cohort of active surveillance patients. So I think over the next 5 to 10 years, we will have a little bit more understanding of these benign biopsies as well.
Thank you very much. And on that note, is there, just wish to ask, just out of my interest, since you are working at a very high volume center, is there any evolving role of system, maybe nuclear medicine scan in oncocytoma, biopsy proven and then further reassurance, you think? Yeah,
that's something, again, we have just started to see, because the positive predictive value of such TB scan is quite high. And again, the advantage from our center is that we carry out biopsies of these small linear masses. And so we can look at the scans, radiological and histological, and hopefully we'll have some answers, more conclusive answers over the next 1 or 2 years.
Wow. That's brilliant. Thank you very much. Asim, you wanted to say something?
I think excellent presentation. I think it's time to move on to the next one, shall we?
Yeah, that's great. Thank you. Great. So moving on the same topic of small renal masses or T1A renal masses, I would just request my radiology intervention colleague, Dr. Sanjay Pillai, who is in his hospital. Sanjay, please, on to you.
Yeah. Good morning, everybody. Or afternoon, wherever you are. Can you hear me?
Yes.
Okay. I'm an interventional radiologist. I'm a general interventional vascular and non-vascular, and renal part forms a little bit of my practice. And I'm not a high volume center person. My experience is limited. That's my disclaimer. I've been involved in ablations of renal tumors since 2002. So I've got, we do about 3 cases a month roughly, and that's a type of level of volumes I do. So I'll try to bring this thing out if I can. I feel like a fraud speaking amongst proper doctors. Just being a radiologist, it's an interesting forum for me to be in this. Thanks for organization for putting me in the middle of this.
Well, Sanjay, we are looking forward to we fully support your service. So
where's the share screen? There you go.
Do you want me to bring it up on mine if you like? Or?
No, I'm just. Hopefully, I will get the technology. I'm supposed to be a radiologist. I'm supposed to be good at these things. So there you go. Share screen. Can you see my screen now?
No, share a screen at the bottom of your window, and then it will come up.
Yeah, that's what I'm trying to do. Is that any better?
It's here now. Yeah, please carry on.
Okay. So this is mainly my experience, and a little bit of understanding of how these things work. So Alan has gone through most of the bits which are relevant and an excellent data-rich presentation. This is going to be just the opposite of it. It's just mainly my experience, really. So this slide just shows what I say to the patient. So as most of you or many of you practice similar things where small renal mass patients are picked up in MDTs, decide to go to specialist clinic where people like Zishan speak to them and decide on what is the appropriate further management. Is it surgery? Is it image-guided ablation? And if that's the case, they come to our interventional radiology clinic. And this is the kind of thing we go through with the patient. Say that, guys, we've seen a lump. In most of the time, these turn out to be cancers. And in about 20% of the time, these are not cancers. So we would ideally like to stick a needle in to get some samples and find out what it is. Please bear in mind that even when you take samples, it is not always confirmatory as to whether it is a tumor, or a malignant or a benign thing. And then a lot of decision-making is in the gray area where patients' state of mind plays a lot in this. So this is a combined decision-making rather than me or Zishan telling patient, oh, this is the right thing to do. So we have moved away from this paternalistic medicine since a long time. Now, RFA is the main thing we do. Cryoablation, we've done some. I find it cumbersome. Microwave is great. Still not very controlled. The colleagues who practice in big centers realize that cryoablation is great. We tend to ablate patients. We wait till the tumor size is around 2 centimeters before we do anything to these ones. And once they hit 2 centimeters, that is when they go to the specialist clinic and progress to whatever way of treatment, if at all. Now, I think there are some trainees in this, so bear with me, the senior colleagues. I'm not trying to to teach you how to suck eggs. RFA, high frequency electric current, causes heat coagulation of protein or cells. So heat of more than 50 degrees Celsius is what makes it happen. The next technique for image-guided ablation obviously is cold or cryoablation. Argon gas delivered under high pressure causes temperature to fall very quickly to -40 to -50, and then you warm it up and go again to another cycle of cooling, and it causes ice crystal formation within the cells, causes cell damage, bits explode and cells die. So that is the basic principle of that. And microwave ablation, electromagnetic energy, again, heat causes coagulation necrosis. So these are the three common ablative techniques we use, and which have been proven to be very effective. Now, each has its own advantage and disadvantage. RFA is one of the oldest techniques. The biggest disadvantages are the size limitation. If there are big blood vessels flowing by the side of it, heat sink effect cause less tissue damage, and incomplete ablation is a real issue which we face very often. In our practice, we managed to ablate approximately 90% of the tumors in one go, the rest in a second attempt. So when I talk about local success rate of an ablation, I count it as not just one. Another attempt is what you would think of it as a cycle, really. The latest kids in the blocks are irreversible electroporation, non-thermal ablation, high volt electric current, short duration, still not in clinical practice. There are centers who are doing them. The main advantages are it only damages cellular structure, so blood vessels, etc., adjacent to it, because of the collagen in them, not cells, are not affected or not burnt or destroyed. So closer to pancreas, closer to blood vessels, a great thing to do, but we're still not there clinical. Now, the oncologist stereotactic ablative radiotherapy, that is the kid in the block we need to watch. There are no needles involved, no anesthesia involved. I'm looking forward to the day when I do not have to stick a needle in. That is that. And another thing which would have been really nice was MR guided ultrasound destruction of tumors. Unfortunately, kidney moves up and down and we can't target it. So we've started trials, or we're about to start trials with brain tumors, and obviously for fibroids it is already there in some centers. With the age of robotics, when you can target moving structures, I'm hoping that this would someday come as another novel ablative therapy. Now, if I just go, some of the people with gray hair like me may remember this kind of radio frequency ablation needle with the tine coming out of it and ablating the tumors. This when we started with these ones, we thought, oh wow, great, fantastic, but the local success rate of ablation was not great because of charring effect close to the needle and the heat not dissipating outside. That used to be the setup. We had to manually move, change the frequency, power, etc. It was a pain. Now this radiofrequency ablation kit is the new, well, not new, I mean around 8 years or so. This has been available where you can pass cold fluid through to the tip of the needle. So what it does is it cools the tissue just around it, around the tip of the needle, so it doesn't become charred and the heat dissipates more to the periphery, and the success rate is fantastic. So you can, I'm sure most of you know that you need an ablation, a normal ablation around the tumor of about 5 millimeters at least to get a good local cure rate. And these ones, they get up to 4.4 centimeters of ablation zone. So for a 3 centimeter tumors, this is good enough. me being a miser, I take the needle out and stick it in 2 or 3 places to get the amount of tissue you need to. Works quite well. I have very little experience in cryoablation. I've seen them, I know about it, but I haven't used them. Microwave I've used a few times before the new microwave systems came in. The older ones, the needles were quite flimsy, and the ablation zones were not, you couldn't predict them well at all. The later systems, they say that you've got good zone of ablation, tight control. I've used them in livers. They're great for livers because you get to large zones. It doesn't really matter how much you burn. So I'm hoping to convert to microwave soon, so we'll see. So a couple of examples. Tumor. So the things I just wanted to show was the techniques where we could use to move bowel away. So if you look there, you can see that colon is close by. So if I burn that, I'll make a hole in it. So if I can get a needle into it and inject some saline or air or something, it'll move the colon away and I can safely ablate it, as long as there is a distance of 1 centimeter between the tumor and the bowel. It's safe to do it. Another a point where it is slightly more risky to do is if the tumor is in the medial aspect closer to the pelvic junction, where damage to the ureter is a possibility. In such cases, if I'll try to avoid if I can. If not, I'll get Zishan's help to get a ureteric catheter and try to put some cold fluid through it. We've done that a few times. Once we have, there was a case where the duodenum, which was very close to it, an abnormal stuck duodenum where Zishan laparoscopically moved it for me before we did the ablation, because it's an interesting lady who did not want an open operation or laparoscopic surgery, but she was okay for Zishan to go in and move, cauterize the duodenum. But there you go. These are the kinds of things. Now, complications, they do happen. Surprisingly enough, or maybe not surprisingly enough, the complications for heat ablation is lower than cryo, and even lower than biopsy. So I've made kidneys bleed by simple biopsies, but I'm assuming that it is due to heat coagulation that these things don't bleed much. Made holes in colons, caused infections. Most of the time it doesn't happen, but they do happen. In the last 15 years, I can remember we've had 1 colon damaged and 3 or 4 infections. That's a sort of approximate kind of issues we face with these things. Now, success rate or local control. As I said before, in 85 to 90% of the time, you get local control in one go. It goes up by a few percentage if you have to do it, if you do it twice. There are occasions where Zishan has helped me and gone and did an operation. I'm not entirely certain that it is more difficult to operate on an ablated tumor. I'm sure Zishan will tell you that. So how I would see this as, or this is how I say to patients that, if you're adamant that this treatment is to be done, I try to put people off this operation because I'm a big believer in less intervention as much as possible. And if we need to treat it, I'm happy to attempt it. You can think of it as an initial process. We're trying to avoid an operation. If we have to, we will get to it. That's the kind of approach I take. Oncological success rate, similar to surgery, but local recurrence definitely, or local recurrence definitely more than partial nephrectomy. That is my ballpark understanding and experience about this. I'll stop yapping. happy to take any questions.
Yeah, thank you very much, Sanjay, for a very, very insightful presentation about RFA. Any questions for Sanjay, please?
Brilliant presentation, Sanjay. Just a point, are you guys still favoring towards RFA rather than cryo? Is it?
I do not do cryo because one, it's cumbersome, I'm lazy, it's more expensive. Those are the reasons for it. It's not because cryo is not good. Cryo is great for the operators because you can precisely pinpoint how much of the tissues you've taken out. But having said that, if you are willing to spend a little bit more of time doing maybe a few punctures rather than one, so let me rephrase it. RFA, you have to place the needle exactly where you need to right in the center so that all of the tumor is ablated in one burn cycle. So, whereas in cryo, you apply multiple needles and they all cook at the same time. But if you can modify your technique a bit by, say, you place your needle in one place, ablate it, and then remove it, and you can re-ablate slightly away from it, you get a similar-ish result. So I do not treat any large tumors. Well, we try to stick to 4 centimeters if we can. We have treated 6 centimeter tumors. That's the largest one I've done successfully. But for those ones, I would prefer to go with cryo if I can. Phase, the guys who work in bigger centers probably are much more experienced in this than I am.
No, sure. I'm just looking at the national trend and the general literature now suggests that cryo is significantly superior to RFA in terms of recurrence rates.
Yes and no. This is what I was saying. In tumors 3, so there are centers who clearly say, so the guys who do the most in the UK, they swear by tumors 3 centimeters or below, doesn't matter what you use. 3 or above, cryoablation, microwave, that kind of cryo preferably is how they do. Yeah, I agree.
Hello, Sanjay.
Hi.
I am Dr. Hafiz from Pakistan.
Hi, Hafiz.
And I have been working at the Indus Hospital, Karachi, Pakistan, the last 10 years.
Hi.
I recently came across with a patient. She is around 58-year-old lady, and her creatinine was 2 because she was a known case of CKD, which is chronic kidney disease. She had a central located tumor, which is measuring about 2.5 to 3 centimeter, which was near the hilum. So it was impossible to go for the partial nephrectomy. So I went for the radical nephrectomy for this. What is your experience regarding this? Either she was a candidate for the RFA or the cryo. So because now she has bit raised creatinine in the post-op period. So what is your experience about that lesions?
Okay, central tumors, definitely cryo better, less damage to the surrounding structures. Having said that, I haven't used cryo, but I've used RFAs in central tumors, and I'm yet to really find a complication related to that. So if I go closer to the central tumors, I try to get Zishan to help me with cold saline infusion or cold fluid infusion in the ureter pelvis. If I'm being honest, cryo is definitely better if we go for central tumors. We would wait for the day when we get the other technique I mentioned, irreversible electroporation. If that becomes successful, that would be the ideal one. Maybe the guys from the larger institutes have experience in that.
Okay, thank you, Doctor.
And you would feel that might need a little bit more close monitoring in terms of follow-up for any residual cancer with a venous invasion risk.
Yeah,
that's an additional thing we could do. Yeah.
Zishan, can I make 1 or 2 comments if you am allowed to?
Please, Professor. We have Shamim Khan with us. Please, sir.
From your previous presentation and this one, excellent presentations, but we have to be very pragmatic where we are practicing. For example, the people listening in Pakistan, there are difficulties in those countries because A, we do not have subspecialization. B, we have a patient population who are
Dr. Shamim Khan.
the patient population who is really not very compliant, and sometimes because of the poverty, they may not comply. So what we are presenting here may not necessarily apply, but what I would urge the community in Pakistan and developing countries, they should develop skills to do operations with minimum morbidity. There was somebody saying that he removed a kidney for a small tumor. Actually, that kidney could have been saved if you sent it to a large volume center with people more expertise. So they would have managed to do a partial nephrectomy and save that kidney. The main problem comes with the burden of follow-up of these techniques. Whether you are doing active surveillance, whether you're doing minimally invasive ablation of these tumors, the main burden is of follow-up, that how often you follow them up, and comes the cost of following up for the patient, particularly in those systems where patients do not have insurance covers, and also the government institutions are not well established to provide that kind of follow-up. So these are the main issues. So coming to your RFA and cryo, definitely we have gone away from RFA in Guy's and St. Thomas's. Andy Adams was the one who led on this, and Tarun Sabharwal. But they have actually given up because mostly it is either cryo or with a robot coming, or partial nephrectomy with minimal morbidity.
Thank you very much, Shamsa. Thank you.
Just one comment. I think excellent presentation on the role of RFA. Just going to the talking about the concept of ablative therapies. Just a question that we've been using these therapies for patients who are unfit for surgery. Are we closer to the point, because partial nephrectomy is a morbid operation in whatever age you do it? Are we getting any closer to offering these therapies electively for patients who are otherwise fit for partial nephrectomy?
I mean, that's a good question, if I may just say, because one of the current national trial, the NEST trial, is going to look at that particular aspect to in a randomized trial, cryotherapy versus partial nephrectomy. And that trial has started certainly at the Royal Free. And hopefully in the next 5 years, we will have some preliminary data to say more robustly whether cryo can replace partial nephrectomy in either selected or most of the tumors safely and with equal oncological outcomes.
That will be interesting. Yeah.
I think again, yeah, I think the main thing is a close follow-up in a large volume center. You can't do 1 or 2 cases or 3 cases and do not have a robust system for following these patients, young patients up. Because if you lose one patient, you know, there should be a fallback position that, okay, patient comes back with a tumor, you should be able to offer him alternative ablative treatment, for example, in terms of surgery, partial nephrectomy. Hello?
Hello. Professor Shamim sir, please carry on, please.
So if you do have a follow-up, a robust system of follow-up where they have come to a dedicated clinic, there is a renal cancer specialist, multidisciplinary, you can follow these patients up, even they are younger, offer them ablative therapies. But the main thing is that the follow-up has to be very watertight. And you can't afford to have a follow-up for this. And then you should be able to offer them, you know. Hello?
Hello, yeah, please. I think if anybody who is not involved.
Ask him question about whether these ablative therapies could be offered to the younger, relatively younger patients. I think it all depends upon, you know, what the patient
भैया
wants.
ये सारी सिस्टम होता कुर्बानी पे बंदे को खुद
Could I please request whoever is not speaking, can they please mute themselves? Can everybody mute themselves while the speaker is?
Ishan, can you not control the mute for from your end?
I mean, everybody seems mute other than Professor Shamim Mumtaz and VNO. I don't know what exactly is this voice coming.
Yeah.
So, you know, what I hope the Faz would agree with me that if these ablative therapies, if they have to be offered to younger population, then we must make sure that the follow-up is watertight and then these patients are, you know, very compliant, coming back regularly, just in case they have early recurrence or something, then they can be salvaged.
No, absolutely. I mean, I think that's a key thing. Even for partial nephrectomies in a younger patient, it's a lifelong follow-up at the current practice, both from the EAU guidelines and the AUA. So I think definitely following ablation, we need to follow these patients on the long term. But I think to offer them as at par treatment, the clinical trials that are ongoing now, certainly the NEST hopefully should answer the question so that we can sort of, with some reassurance, tell our younger patients that the treatment is effective. But again, clearly they will need a long-term follow-up.
Great. Thank you very much for another very useful discussion. Shall we move on to next talk, please?
Michael mute. Michael mute.
Okay, right. So I would just request Mr. Faz Mumtaz now to just please speak about partial nephrectomy, if you could, please. Could I again ask everybody to mute themselves, please, who are not involved in the presentation, except Mr. Faz Mumtaz? Thank you.
I'm just trying to log on to my share screen.
Yes, share screen.
And my presentation is on the desktop.
So if you share a screen, please press the share screen button on the bottom of the Zoom window.
Yeah.
And hopefully it will sometimes take a second or two.
Sure. Has the previous person logged out?
Yes, he has stopped sharing. He has already stopped sharing.
Okay. Why is it not? I thought it would be.
So it's
Looks like Dr. J. Kumar has just come on.
You must open the presentation before you share this.
Yeah, it is open.
Yeah, okay. So just press share screen. Is anybody else sharing a screen? I don't think so. So just share a screen button again.
Yeah, that's great.
You must open the file first before you share.
Yeah, no, I have opened. Interesting. You want to do the next presentation then? I mean, I'm struggling. Give me a minute or so, but it should come through. The last time it did.
Is it okay if we move on to the next item? So if you want to email me that, I can as a backup in the meantime.
Okay, I'll do that.
Yeah, just reply to my email and then we can just go on. Okay. Right. So shall we just move on to the next talk, please? And we were, after this talk, we were meant to just go on to locally advanced kidney cancers. And so we have Mr. Pradeep Bose, who was my very own mentor in Swansea, just to talk about IVC thrombus tumors and the approach for nephrectomy. So it's in two parts, and following that, Mr. Zaid Mahmood, who is consultant cardiothoracic, will just give a 5-minute talk on cardiothoracic side of that. So please, Mr. Bose, if you could start.
Thank you. Zishan, can you see my slides, please?
Yes, I can, and you can just turn the slideshow, please. Thank you.
Do that now. Okay, is it okay now?
Yes, it looks absolutely fantastic.
Good morning, everybody in UK, and good afternoon in Africa and Pakistan, and Assalamu alaikum. It's an honor to be here, and thank you for inviting me, Zishan. It's good to see you again.
Thanks for having you.
Now, I thought I'll better point out where we are actually. Swansea is not a big city. We are in Wales. You can see the little arrow there. We are the second largest city in Wales, but despite being the second largest, our population is about 300,000. We cover a population of 1 million. We are the cancer center. We are a small fry compared to rest of the units. We do about 100 nephrectomies a year. I don't just specialize in nephrectomy. I do pelvic cancer. I also do the penile cancer and groin dissection. There's not a lot to know about Swansea. We are in the Premier League, but not anymore, unfortunately. But just around Swansea, you've got the Gower Peninsula. And this is not a made-up picture. This is a picture taken before the lockdown. So it is always worth a visit. Just a word of warning, it rains a lot here. And it's raining today as well. Now, coming to the business. Well, surgery for locally advanced renal cancer, I still find it is the most challenging of all urological surgery. It can test your physical and mental endurance to the maximum within a very short period of time. But the good news is that once you get a patient off the table, then you don't get much problems. If you've done the operation properly, it is not like cystectomy where you have a urine leak or a bowel leak or this and that. Patient usually go home in about 5 days and they don't cause you much grief. So what is the key to success? The first thing is preparation and planning. It's very important. Don't get too hooked up about the IVC thrombus. Sometimes removing the kidney is actually more challenging than taking the tumor thrombus out of the IVC. A good exposure. Larger the incision, better the surgery. That is the dictum for renal surgery. Don't try and operate through a manhole. And always prepare for the worst and hope for the best, and things work out better. Now, the thing which I've highlighted in bold is that what we usually deal with, usually T3, T4, N1 disease, occasionally a large T2B. Well, T2B are getting less and less because if your laparoscopic colleague is good at it, then he's not going to give you that. One word about the T4. Usually the T4 is involvement of the adrenal. It's very rare for the tumor to involve liver or things like that. Occasionally bowel or colon, which you can resect, which is not a bigger problem with. Now, this is the repertoire of surgery we deal with. You can have a large T3, A tumor. You can have a T3 with the renal vein. You can have a T3B going up to close to the hepatics. You can have a T3B or T3C, which is going right up to the atrium. And of course, you can have a tumor which is small, but you've got a paracaval lymph node. So this is the bread and butter of our work, really. Now, the first question a surgeon should ask, is it worth doing? Are you trying to do anything good to the patient? And this is slightly outdated data, but again, you can see that the median survival is about 52 months for T3A. And even with T3C, it is 18 months. And this is a little historical data because TKI and the immunotherapy hadn't been in vogue then, and I'm sure the survival is better. And the other thing important thing to remember is that it is a very effective way of palliating the problem. A kidney tumor can cause pain, bleeding, and so forth, and you can take that out. And an operation of nephrectomy doesn't cause problems like incontinence, like radical prostatectomy does. You can give the patient a very comfortable life. So, nephrectomy was standardized by Robson and his colleagues in 1969, and the classical description of nephrectomy was that early ligation of renal artery and vein, removal of kidney with the gyrotous fascia. Robson advocated ipsilateral adrenalectomy. That's a bit controversial now. Regional lymphadenectomy, again, that's a bit controversial. He didn't talk about IVC thrombectomy, but that has been added to the repertoire of nephrectomy. So what surgical consideration we need to have, apart from doing the nephrectomy, is that do we need to take the adrenal out? The answer is simple. If it is being directly involved, or there is a high risk of invasion, which is apparent on the CT scan, we take the adrenal out. Usually it is a propol tumor. A few other questions I'll address before I go into the main bit. What is the role of preoperative embolization? Should we perform lymphadenectomy? And is there any role for cytoreductive nephrectomy? Now, preoperative embolization, the main advantage of embolizing the renal artery is the fact that you can ligate the renal vein without ligating the artery. So it makes the operation slightly easier. It doesn't reduce the bleeding. In my experience, the bleeding all comes from the collaterals. If I ever do it, I very rarely do it. I preferably do it the day before surgery. And you have to remember that these patients will have pain, so they have to have a PCA or some form of analgesic. You need radiology expertise to do it. And the coils are expensive, as probably Dr. Pillay will agree. It is a taxing on the radiology department. So I very rarely use it. And this is just a slide to show you that the coils are within the renal artery, the two renal arteries here, both have been coiled. Now, what about the lymph node? Should we be doing a lymphadenectomy? A few points. The lymphatic drainage of kidney is variable. The traditional teaching was that if it is a right-sided tumor, it is paracaval, interaortocaval, left-sided paraortic, interaortocaval. But that is all a conjecture, really. The other thing is that 20% of the enlarged lymph nodes are cancerous, the rest of them are reactive. We haven't got any other test reliable to tell us that whether these lymph nodes are positive or just reactive. So when it comes to clinically negative lymph nodes, large retrospective studies have shown that there is no added benefit. And in fact, I don't do it routinely, but there are some large centers like Mayo's and maybe some in UK who do it for patient tumors with high risk, which are large tumors, sarcomatoid changes, or tumor necrosis. And it is not an easy operation to do a lymphadenectomy. What about clinically positive lymph node? EAU recommends, guidelines recommend, LND recommended, but it doesn't tell you exactly what you should be doing. Should you do a template like testicular tumors, or should you just excise the enlarged lymph nodes? What I do is I just excise the enlarged lymph nodes because I believe that if they are negative, then it gives us useful information. If they are positive, I don't think I've cured the patient, but it may have debugged the disease, and the need for having systemic treatment is delayed. However, it is challenging surgery, and you have to choose your patients carefully. If you've got a large paraortic lymph nodes all involving the whole of side of the aorta, I don't think there's anything worth doing because you're not going to cure it. Removing the lymph node is a difficult operation, and unless you're doing RPLND regularly, I don't think you should attempt it. So in my practice, if they're enlarged, if they're easily removable, take them out. Otherwise, I don't mess with it. Cytoreductive, I know my colleague is going to talk about it, so I won't dwell in too much, but sometimes we do get arm twisted to do a cytoreductive. And the simple rules of cytoreductive nephrectomy, in my opinion, is do it on a patient with good performance status. The renal burden, the tumor in the kidney should be much bigger than the metastases. Especially the tumor is causing symptoms. Best results are with lung metastases, especially solitary, because you can sometimes cure them by resecting excising the lung met at a later date. Don't try and attempt it if there is liver, brain, or bone metastases, because they don't do very well. And patients who have got rapidly progressive disease or not that fit, don't try it, because all you do is you cause them more harm. They never recover from the surgery to ever receive systemic treatment. So what is the preoperative preparation? You should have an updated CT imaging. That is the mainstay of imaging, really, thorax, abdomen, and pelvis, contrast CT. MR scan in selected cases if you're not sure about the level of IVC thrombus, or sometimes the kidney tumor is touching the liver and you're not sure whether the liver is invaded or just in close opposition to it. Sometime with borderline cases where T3B or T3C, whether you want your hepatic colic or your cardiac colic to be there, the imaging day before the surgery is helpful. Planning incision, beforehand. Embolization if required. Check equipment is available. Ensure blood is available. The last thing you want is when there's a blood hosing out of the IVC and your house officer has forgotten to cross-match. And line up help. Hepatic, vascular, or cardiac surgeons. Hepatic are the most useful. Vascular next. Well, I think vascular very rarely are that useful, to be honest, because they mainly deal with artery, not with veins. And cardiac surgeons, of course, if you need them. My principle is this: if you tell your colleagues that you're going to do a difficult operation tomorrow and we may need your help, they are very helpful, and the word doesn't get around that PAUS needs a lot of help. If you call them in the middle of the operation, you get a bad name. We try and avoid that. So one thing is there, renal surgery does not need any expensive instruments. You can actually do an operation through basic instruments, a few slings. If you have got vascular slings, great. If you're not, we used to use Jake's or red rubber tube in India when I was training there. But if you have some of these instruments, it makes life easier. One is a self-retaining retractor. If you can get OmniTrack or Thompson, it doesn't have to be a urology department owned one. If the surgical division has one, it helps all the departments. If they are expensive to buy, but once you get them, it lasts forever. Vascular clamps, Satinsky and Bulldog clamps are very helpful. Liga clips, if you got them, I use the reusable ones. They're cheaper than the disposable ones. It saves a lot of time tying little lumbar veins, especially dissecting by the side of the IVC. Ligature and harmonic, if you can afford that, and if you can get it, it changes your life. And it reduces bleeding from the collaterals. It's mobilizing the kidney and the colon, and the lienorenal ligament makes life so much easier. In fact, we do these operations, pelvic cancer as well as renal cancer, much quicker nowadays, simply because we've got these gizmos, not that we are better surgeons. And of course, if you want to reduce the risk of blood transfusion, you can have a cell salvage. We use cell salvage routinely in Swansea. Now, planning the incision, you can do a transabdominal. I prefer transabdominal, usually subcostal Lexus or Mercedes-Benz, as the name suggests, the same shape. That is the bread and butter incision. You can use a thoracoabdominal, especially if it's a large apopole tumor on the left side. It is good for the surgeon, thoracoabdominal, but it's not good for the patient because a painful incision, it takes longer for the patient to recover. Midline, in my opinion, is a useless incision. I find it extremely difficult to do kidney operations, but once in a while, you may have a thin patient with a narrow costal angle and a large lower pole tumor. It's a good one for that. Flank incision, only used for partial. Nowadays, I don't do it for radical. Nagamatsu, I've only read it in the book. I've never seen or done one. It's supposed to give you an excellent exposure, but it's very painful. This is the standard Mercedes-Benz, and if you take one limb away, it becomes a Lexus. As my oncology colleague once joked, that thank God you don't have to use a high one die incision. No, we don't have to use that. This is what helps. So just to give you an example, this is a large upper pole tumor, no IVC involvement, and high risk of injuring the spleen. If you did a thoracoabdominal, exposure is excellent, life gets very easy. Now, what are the operative steps? You are all, speaking to senior urology colleagues, so I won't go into details, but I'll just outline the basic steps. You do a incision, then mobilize the colon. On the right side, you cauterize the duodenum. On the left side, you open the lesser sac and mobilize the pancreas and spleen out of the way. Then I put in the self-retaining retractors, pack away bowel. Ideally, both your hands and your first assistant's hand should be free when you're doing complex renal surgery. Because when things go wrong and it starts bleeding, you need help and not one hand busy retracting part of the bowel. I tend to mobilize the lower pole of the kidney gently and divide the ureter and gonads so that I can create a space between the psoas and the renal pedicle. And if there is no renal vein thrombus, then if you do have inadvertent bleeding, you can always put a Satinsky clamp and deal with it. This is a good maneuver to do before you let your registrar mess around, because you know that if they make a hole in the vein, then you can always clamp and get away. And then the steps are straightforward. You control the renal artery, then the renal vein and IVC control, mobilize the kidney, then remove the kidney and the thrombus. close the incision. I don't routinely put a drain unless I've done some bowel anastomosis. So this is a shot about where we used the Thompson retractor, and you can see the falciform ligament have been divided. You pull the chest ribs high up, and it gives you an excellent exposure. Splenic injury is a known problem on the left side, and this can be avoided if you divide the ligaments early and don't put any traction before you do that. So when you're mobilizing the colon, you divide the splenocholic ligament early. And if you mobilize the pancreatic body and tail out of the way by opening the lesser sac, an early division of the linorenal or splenorenal ligament before you mobilize the kidney usually protects the spleen. This is another trick which you can use. This is a right-sided tumor, and sometimes if you have got a bulky tumor, it's difficult to find the renal artery because the renal vein is sitting right there and the artery is behind it. You can find the artery between the IVC and the aorta and tie it there. Usually the clue is that it is either just behind the renal vein or just beneath it. And if you do that, then life gets easier. You can then tackle the renal vein. So that is mainly about the T3A tumors. Coming to the T3B, again, go back on the old things. The first thing is to make sure that you got up-to-date imaging. And sometimes if there's any doubt that whether it is level 2 to level 3, or when I say 3B to 3C, or whether you need the hepatic surgeon, if they're a thin patient, you can get an ultrasound scan the day before surgery or limited CT. So you need to know how high the tumor thrombus is. Has the tumor infiltrated the wall of the IVC? It is unusual, but if you're working in a large center, you may get more of these patients. Is there any chance of needing a graft, cable graft, end block excision? It is very, very rare, I must stress. And of course, whether you need a cardiac surgeon, then obviously you need help. So how do you approach? It's the same thing, a Mercedes incision, control IVC below and above the thrombus, control contralateral renal vein. Beware of the lumbar vein, especially the L1. Sometimes the L1 could be as thick as my forefinger and it can cause torrential bleeding. Mobilization of the liver. If you're just doing the caudate lobe, you can ligate the branches of the caudate lobe, the short hepatic branches. But sometimes if you want to do a complete mobilization of the right lobe of the liver, you may wish to do it, or you could get a hepatic surgical colleague to do it for you. So now, in my opinion, a level 1, I think most urologists would cope without too much trouble who are used to doing open surgery. A level 2 is slightly more complicated because you have to tie the short hepatic vein, so you have to be aware, you have to have good retraction. Once you get to level 3, then you can do it, provided you're confident enough to mobilize the liver, or you can get a surgeon to help you out. In my experience, if you can get somebody to help you out, it makes life a lot easier. It dissipates the stress. Removing the kidney and doing the operation itself is hard work. If somebody does a bit of the job for you, life is easy. And of course, if it is higher than that, you have to speak to your cardiac colleagues. A few tricks: exposure of the lumbar vein. There are 2 things you have to watch. Firstly, that you roll the IVC. So you can either roll it with your finger or you can use your pledget. So you can actually roll the IVC, see the edge of the IVC, and that's how you get a sling around it. And you can see a big, large lumbar vein. And if that bleeds, you can have your operation can turn into a mess. So now, early T3B, where there is just a little nubbin of clot going into the IVC, you can side clamp with the Setinsky underrun it, straightforward. In this case, you can see that the caudate lobe has been mobilized and the little hepatic veins have been ligated. And there's the IVC left renal vein. Another little trick is that you can see the free edge of the lesser sac. That's the porta hepatis, the portal vein and the hepatic artery. If you get bleeding from the liver, you can always put a little clamp, Setinsky clamp on it, as we call the Pringle maneuver. Now, if you wanted to go a bit higher up, then you have to mobilize the whole right lobe of the liver. You have to divide the right triangular and the right anterior border of the coronary ligament. And you can actually then move the liver to expose the whole of IVC. And if you do that, then you can go right up to the top and get up to the hepatic veins. Now, how can you determine or guess whether the tumor is going to invading the IVC wall. If you have got a free floating tumor, we can see a bit of IVC by the side, then they are the easy ones. The problems are these ones. This is where there is a chance that the IVC wall may be infiltrated. And I'll be pretty honest with you, I have never done this, where you have excised the IVC and put a graft. Usually in my experience, you can excise a bit of the IVC wall and just close it without putting a patch for two reasons. Firstly, the tumor thrombus has already distended the IVC anyway, so even if you reduce the lumen, it doesn't matter. And secondly, most of these patients have already developed collaterals and you get away with it. I'm a bit skeptic about talking with my vascular surgeon. I'm a bit skeptic about how well these grafts work because it's a low flow venous system. It probably clogs up anyway. Now, if the tumor thrombus is going above the hepatic veins, if you want to make your life easy, call your cardiac colleagues and do it on a bypass. But if you wanted to be brave and if you have got the expertise, you can try two maneuvers. One is you can do a Pringle and at the same time apply a clamp at the IVC at the suprahepatic level. So that is one option. This is one of papers presented by one of our Chinese colleagues about 10 years ago. Or if you have got really skilled hepatic surgeons, they can mobilize the liver completely and get your finger around it. That's not an easy operation. If you are, one word of advice, if you're actually mobilizing the liver, you ask your anesthetist to lower the central venous pressure, because if you lower the central venous pressure, the liver, which is a hard, firm organ, suddenly becomes a floppy organ. Just remember that. But in my experience, if you get a case like that, you better get the cardiac surgeons. We don't do the patient on bypass here because the numbers are very few. We send them to Cardiff. Now, a few tips about if you do have an injury to the lumbar vein. This is an old slide, actually. This is by our late Andrew Novick, who was, as you know, was a great renal surgeon. And what you do is that you roll the IVC, you put a Babcock or a Duval onto the edge of the IVC, and then you can underrun it. If you get into bigger trouble when you have a laceration on the IVC, well, the first thing is not to panic. You can put a finger on the IVC and you can stop a bleeding on the IVC, so you put the finger in the right place. The second thing is you tell all your anesthetic colleagues and theater staff to stop the chattering because you are in trouble. You can get your assistant to put pressure above and below the IVC with a swab, and usually the bleeding gets less, and then you apply the same principle. You put little Babcocks, and then you can underrun it. Complications, perioperative, you can get bleeding, which can occur from the avulsion of lumbar or adrenal veins, which I've already explained how I deal with. Slip clamps on the IVC. The best thing is to have a sling as well as a clamp. A slippage of renal vein suture, particularly on the right side, because the right renal vein is very wide. In my practice, I always side clamp the IVC with Setinsky and underrun it. Even if they haven't got an IVC thrombus, I still do the same. I sleep well. Splenic injury, if you divide the ligaments early, you can save yourself hassle. Nowadays, most of it is usually capsular tear, and they stop with flow seal and Surgicel. Large bowel mesentery, you can excise large bowel mesentery with the tumor, usually get away with it because the vascular arcade preserves the colonic blood supply. Bowel injury is usually because of diathermy. It's very unusual in open operation, more with laparoscopic. Beware, if you're doing a lot of these, sometimes the anatomy is distorted, especially large left-sided renal tumor, and make sure that you're not tying the superior mesenteric artery, thinking that that's the renal artery. And liver injury, again, if you divide the falciform ligament early and protect the liver when you're putting traction, it's not a problem. Post-operative, the usual complication, bleeding infection, DVT. In UK, most centers now with major cancer operation, they go home with low molecular weight heparin for 28 days subcutaneous. Ileus is a problem, but it's not as big a problem as cystectomy, to be honest. And my simple principle is that the next day they go on free fluid and diet. I tell my patient, if you're hungry, you eat. If you're feeling sick, don't. You can get problems with massive transfusion problems, coagulopathy. Renal failure is usually transient, sometimes because you have clamped the renal vein on the contralateral side. If you deranged liver function can happen if you have put a clamp on the IVC above the liver, and obviously the complication related to bypass surgery. Mortality, I usually quote my patient, the mortality is less than 5%. This is more historical data. Actually, it all depends how you select your patient, to be honest, but it is acceptable mortality. And after a hard day's work, I usually have a little banter with my anesthetic and surgical staff. We try and guess how much blood loss it was, and that is the usual response. And I'm sorry if you're upset with the slide, but that's the way life is. You have to have a laugh after you finish your operation, really. And thank you for your attention.
Fantastic. Thank you very much, Mr. Bose, for speaking on a very extensive topic.
Sean, can I make a comment?
Yes, please, please.
Yes. Thank you very much, Pradeep. That's an exceptionally good talk. Few comments. I think you made a point very validly that perhaps it didn't come across for those who are not used to this kind of work, that on the right side, if you want to get an access to the right renal artery, like Mr. Pradeep showed in this imaging, it's the left renal, the angle between the IVC and the left renal vein. That's where you look for the right renal artery. And it's a very, very useful trick. The second, just a comment, Pradeep, you're right. Many times you can get away by cable bypass. And I find that if you set yourself up for TVE and the Pringle together, the liver can shrink into a very small sort of organ, and you can mobilize both the coronaries and the triangulars and the Makuchi, and then you can go all the way up to the hepatics. And if you divide the left and the right subphrenic vein, you can deliver the pericardial ring for 1.5 centimeters. And if that gives you enough space for cable bypass. So you got a segment where you can work to enhance the life. But the only problem is you have to do whatever you want to do within 45 minutes of ischemic time. And the other thing that you did mention, but I find Catal-Brash maneuver and keeping the bowel completely out of the abdomen very helpful. Thank you.
Yeah, I entirely agree with your comments, actually, Mr. Alam. And I think because I haven't got any experience on venal clamps bypass, so that's why I didn't mention it. But thank you for bringing it up.
Thanks, Mr. Bose. Yeah, thanks, Ashar. Nice. Professor Naeem wants to make a comment, but could I please just request that Mr. Zahid Mahmood, he would just briefly speak for 5 minutes about the cardiopulmonary bypass side of it, and then we could just come to questions with Mr. Bose's talk and the whole topic. Is that all right? Thank you, Mr. Mahmood. So you please carry on.
Good morning from Glasgow to everyone. I work in Cardiff a few years ago as a registrar, and Swansea and Cardiff has very good cardiothoracic facilities at that time. And as Pradeep mentioned, Glasgow is similar like Swansea. It's raining at present, and but very nice scenery, a whole of Scotland, for those who are not in Scotland, I will recommend them to come and visit Scotland. So thanks very much, Zishan, for inviting me to talk on that very topic, and very informative talk from Mr. Pradeep Bose, and very well detailed. I will just point out a little bit on the indications and the cardiopulmonary bypass, and I will let Zishan and the other colleagues discuss. So when you have a renal cell tumor which extends above the diaphragm. Below the diaphragm, as the team knows, that unlikely you will need bypass, but in certain circumstances, Pradeep mentioned that when it's involving the hepatic vein, there may be a requirement. And pre-op early discussion with a cardiac surgeon where you have the facilities is very important. So the indication in terms of renal cell carcinoma, hypernephriomas, or in children, Wilms tumor are those ones who have an extension above diaphragm, maybe coming up into the right atrium or obstructing the tricuspid valve, or maybe they also have a pulmonary embolism because of the tumor or thrombus extension. So it's a very challenging procedure with the right atrial thrombus. And as I mentioned, it has to be a collective team effort by a urologist as well as cardiac surgeon. It requires cardiac anesthetist and perfusionist to optimize the patient on cardiopulmonary bypass. And there is different techniques you can put it on bypass, which one is that with the hypothermic circulatory arrest, and the other one is with moderate hypothermia. With the hypothermic circulatory arrest, you have more bloodless field, but when you cool down, there's a more risk of bleeding, and subsequent, there's a more risk of stroke and increased complications. And few centers have also performed with moderate hypothermia with quite good success. So as you can see on this diagram, that on the red side, on the top of that, there's the aortic cannula going in, and at the bottom, below the renal veins, we'll put an IVC cannula. And you can see on that diagram, the tumor extend up to the IVC and very close into the right atrium. So what we do on bypass, put an ascending after heparinization, then we'll put an ascending aorta cannulation, then venous cannula for the venous drainage. One goes into the superior vena cava, and then below the renal veins, I just showed in the previous slide. I prefer to be on a moderate hypothermia because there's a chances of less bleeding, and without cross clamp or cardiopulmonary arrest. Then after doing that, as I mentioned, it's a teamwork. My urology colleague will open the cavotomy and then go into the renal vein. And it depends upon what the process they want. They might do an endoluminal occlusion catheter on the top, and then do the thrombectomy and radical nephrectomy. So that's all I can say on terms of cardiopulmonary bypass. If there's any question, I will be happy to answer relating to that. And thanks very much, Zishan, for giving me the opportunity to have a talk on that. Thank you.
Thank you very much, Mr. Mahmood, for giving a mental picture to obviously some of those who haven't experienced such an advanced surgery so far. So Professor Naeem, I'm sorry I couldn't take your question at that point. Would you please, if you would, had a comment to make or a question to ask, Professor Naeem? Right. Great. Yeah, we would really welcome further comments from any other senior colleagues who have experience with this. Just to enrich.
Yeah, this is Dr. Saeed Akhtar from Pakistan. Excellent presentation, Pradeep. A couple of points which are very important that we have learned over time. One is that when we are doing a left-sided tumor, and obviously all our focus is on the kidney, one of my patients had a recurrence in the gonadal vein, maybe 5 years down the road. So since that time, we have started to actually, because tumor goes retrograde and we are not paying attention towards the gonadal vein, we take it wherever we think it's appropriate. So if you're doing a left-sided tumor, please go down the gonadal as low as you can. That's one. Secondly, when you are opening the, before you do the craveotomy, I would recommend that take 2 5/0 Prolene stitches at the site where your top and bottom incision of the craveotomy would be. And as soon as you pull out the tumor, lift it up with those 5 Prolene stitches, and then you're ready to fire a side clamp Stinsky. So that'll actually you have more control on the vena cava. One of the most important thing that I think I want to share here is don't forget about the bland thrombus. When there's a thrombus, which is a tumor thrombus going into the IVC, there may be a bland thrombus below. And so I always bleed the distal vena cava so that if there is a bland thrombus, it doesn't kill the patient by throwing up pulmonary embolus. Thank you.
I think they are very good points. Regarding the stitches, I do that as well, but sometimes I actually put a Babcock at the 2 ends. And regarding the bleeding the IVC, what I should have mentioned also, when you close the IVC, just before you take the last stage, I open one of the clamps, the lower one, just to get blood out so that you reduce the risk of air embolus. Thank you very much.
Great. I think it would be really interesting from colleagues in Pakistan, because I think from a limited experience during high job, there was a lot more advanced cancer cases that we used to see there. So I think any further comments would be very welcome, just to enrich our knowledge on the approaches. Just one question from my own early years of consultancy and real work, that Mr. Bose and all senior colleagues, that if we go in for a planned IVC thrombectomy, and especially cardiac thrombus, which are planned to have a cardiopulmonary bypass, and this is very ideal what you mentioned, Mr. Bose, about getting a scan done a day before. But let's say if there's a bit of a lapse and intraoperatively, just after the incision, you find big blobby liver mats palpable. What would be the approach you would? Shall we still go ahead and perform the procedure, bearing in mind the morbidity associated with that, or do you think it is too late and the best approach is to take a biopsy, close the patient, and then patient could go on to palliative systemic treatment rather more early?
Sorry, Zishan, did you say that you open up and you find that there is metastasis in?
There's metastasis in liver mats, for example, which was not on the CT scan a month ago. So at that point, is it worth still going ahead with such a morbid operation, which might just delay any further systemic treatment and patient will miss the window of opportunity? Or would that be more advisable that we simply just take biopsy intraoperative and go on to systemic treatment, which can be started much more sooner?
I think that is where the principles of cytoreductive nephrectomy comes in. If there's a large tumor and the CT scan before hadn't shown any mets and you picked up a solitary liver mets, and if you think that you can, and the patient is otherwise fit and well, I would go ahead and do the operation and then you can finish it. Once I've been caught out in a different situation where the tumor actually had gone and needed a bypass, and you have opened the patient, and then what do? I actually close the patient, because we don't do the bypass in Swansea, although we have got a unit, but we don't do it because we only get 1 or 2 or 3 patients a year in the whole of Southwest Wales. I closed it, explained to the patient, spoke to my colleagues in Cardiff, and he had an operation the next month quite successfully. So the most important principle of the surgeon is do no harm. And always remember that there's nothing wrong in backing out if you think that the patient will be better served in another center.
Right. Okay.
Okay. Zishan, can I make a comment?
Please.
Yeah, I think Pradeep is very right, and I think it all depends on your personal expertise. If you have a liver surgeon assisting you, it very much depends what you've discovered incidentally. If it is only a small area, and let's say if it's affecting segments 6 and 7 of the liver, then it's very easy that you can do a Glasgonian resection of those 2 segments on table, and depending where the thrombus is. But if you are doing the whole thing yourself, and obviously not au fait with the Glasgonian resection, then the best thing is what Pradeep suggested, is to send them over.
Right. Thank you very much. Thank you very much.
Zishan, can I make 1 or 2 points, please? Yeah.
Please do, please.
So, the Pardeep's presentation was brilliant, very, very practical, very well demonstrated. But what may I suggest to our friends in Pakistan, that if a patient needs a bypass, then it has to be done in a cardiac theater, not in the urology theater. But plan it well ahead, a week or 2 in advance, discuss with them, have up-to-date imaging, so that on the day you are not surprised with unexpected finding that you are in trouble. Regarding embolization, I think it's something which we occasionally do in guys, maybe once or twice a year, not very often, but we try to do it on the same day as the operation. So the patient goes to the radiology first, gets embolized, and then goes to theater from the radiology department for the operation. We don't do it day before, but we rarely do it. But if we decide to do it, then we do it just before the operation theater.
Thank you very much.
Only at the point I would like to add, totally concur what Professor Khan has said. I think certainly in Pakistan, and of course it happens here, these are very rare tumors, and it has to be highly centralized. There's no point doing 1 or 2 such tumors a year. I think centralizing it, developing a multidisciplinary team approach, and ensuring that you have the cardiac surgeon, the hepatic surgeon, the urologist, the pathologist, and a dedicated anesthetist as well on board. And as Professor Khan has said earlier, to plan these definitely ahead. And I think the key word from my perspective is that it should be highly centralized and not to be done ad hoc once or twice a year.
Right, okay, thank you. Thank you very much. I think that's the key message here, preparation well before the surgery and centralization with this, whichever setup you're working with, the UK or in Asia or subcontinent. Great. Professor Naeem, I think if you wish, you might have to unmute yourself just to, I think you wish to make a comment, Professor Naeem. Okay, right, not sure. Great, so shall we move on to the next slide? Thank you very much, Mr. Bose and Mr. Mahmood, for your very, very fantastic talk. So we'll move on to partial nephrectomy now for localized renal cancer. Mr. Mumtaz, please, on to you.
Yeah, thank you so much, Zishan, and my apologies for not being able to log on. I think it's partly the technology. The whole computer was set up on iCloud, and that's why I couldn't download it to your presentation. You learn every day.
No problem.
So my apologies. And thanks to Professor Mumtaz also to organize this webinar, and to Asen Bhai to plan this, and for the invitation to give a little talk on partial nephrectomy. Clearly, I think the issues of partial nephrectomy relate to, I mean, it's a procedure that's been done now for more than 100 years, but over the last 3-4 decades, it's seen a massive shift from, also because from the indications and from the technique, from open to laparoscopic, and to more recently, over the last decade, robotics. And certainly even in the UK, it's a relatively a new technique being established over the last decade. And the reason why there's been a change in practice of partial nephrectomy is that, as we understood earlier, that we are now recognizing large majority of the tumors that present to us are as small renal masses. And about 50 to 60% now present like that. And it's incumbent upon us to preserve renal function, partly because there's a high prevalence of an aging population, CKD, diabetes, hypertension, and other things that impact on renal function. And as such, when you find a small renal mass, a lot of work is being explored into active surveillance, ablative techniques, and certainly when a surgical procedure is needed, a partial nephrectomy. And the essence is to carry this procedure out in the most minimally morbid fashion. Of course, the main principles of partial nephrectomy were laid down by open procedure, and that is excision of the tumor, internal venography, reducing your warm ischemia time, and preserving as much of the nephrons as you can. And the reason why it moved on from open to laparoscopic to robotics is because of the emerging technological advances. We currently have robotics as the key thing, but I'm sure in the next decade we will have artificial intelligence supported robotics. And more recently, I think we've had a major impact from the coronavirus. We centralized these complex tumors into hospitals, centers, which have now been impacted upon by this COVID pandemic. And as such, a lot of work had to be shifted to other cold site centers. And that is giving a new framework, a frame mind to see how future complex surgical procedures will be carried out, because this is not going to be the last pandemic. We've learned a lot of lessons, and over the years, one would be expecting more of this as we go along. Let me see my slide. Yeah. So we have alluded to this. This is the center where I work, large high volume center we established over the last 5 years, where we are now currently carrying out at least 500 renal cancer surgical procedures, seeing about 1,500 to 2,000 patients a year. And this is the team that I work with. We recently celebrated over 5 years of robotics. And the center here is our current cancer lead, renal cancer lead, Axel Becks, Maxine Tran, Ravi Barod, Prasad Patki. These are other surgeons. We have the anesthetist, a fellow nurse specialist, and a visiting professor here to mark the event. So it's not something that has been there for years or decades. So robotics, certainly even in the UK, in high volume center, is just 5 years of age. And the reason why that has happened, over moving from laparoscopic to robotics, is because of these national trends now. It's patient driven, and largely what drives the robot is the patient, because essentially they want to return back to their normal activities fairly quickly. And other stakeholders within this driving the robot is the surgeon. Of course, they want to learn the technique and be more economically conducive. And from the public health economic point of view, we want to see whether robotics is cost effective. And then industry also looks into promoting their tools from a marketing perspective. And a balance has to be achieved to see whether this thing is beneficial, merely keeping the patient into the core of the whole argument. So from a surgeon's perspective, we're very clear the advantages of the robotics. I think the main thing is the micro wrist that is attached to the end of the laparoscopic instruments. It's intuitive, 3D images, and more importantly, I think it's the shorter learning curve compared to the laparoscopic partial nephrectomy. And as a result, we see that clearly the robot is on the rise. And that's back an old slide, but now if you look at it 2020, it's certainly at the Royal Free Hospital, where 150 partial nephrectomies were carried out, 98% were robotics. So that is the trend. And the reason for the trend, as I alluded to, were the advantages related to the robot itself. The learning curve, as I alluded earlier, is usually down to about 16 cases to establish the learning curve. But of course, more data now suggests that, of course, you never stop learning. Even if you've done 500, you still keep learning. Your learning curve to reduce the warm ischemia time is somewhere between 26 to 30 cases to an acceptable levels to open surgery. And this was the paper that concluded that even when you're carrying out up to 200 to 300 procedures, your operating parameters to show that improvement continues that continues even up to 300 procedures. And we see that as we are in a high volume center, we see complex cases, and there's a desire to carry out more challenging cases as we go along, and the expertise for open surgery is reduced. So the robot is facing a lot of challenges as we go along. Looking at the effectiveness and the functional outcomes, here's a meta-analysis to evaluate the safety and effectiveness of the functional outcomes between robotics and laparoscopic. One could see that the robotic partial nephrectomy could allow us to perform partial nephrectomies on larger tumors with higher nephrometric scores, less risk of complications, less risk of conversion to open, and certainly a much shorter warm ischemia time. And these are significant advantages. The reason why there were similar post-operative EGFR, this is slightly again an old slide. I mean, looking at our current data on blood losses, I think the blood loss from in 80 to 90% of the partial nephrectomies is usually less than 50 mils. And the operative times are decreasing as well with further experience. But the reason why GFR remains there's no significant difference is partly because the main determinants that determine post-operative GFR is the quality of the renal parenchyma and the quantity of the renal parenchyma that you preserve. And that was easily shown. And these were independent predictors, even when taking into account the warm ischemia time. Overall, this meta-analysis also concluded that robotic partial nephrectomy had superior outcomes. That's more recent data. As you can see that overall, looking at blood loss, complications, hospital stay, GFR and recurrence rates were much better with robotic partial nephrectomy compared to open. And similar things were seen with the laparoscopic comparison as well. From the oncological outcomes, the 5-year survivals were as similar to open surgery, ranging between 90 to 97.5%. So from an oncological perspective, there were no concerns with the robotics. Now, cost is a very contentious issue. One could look at the cost within the short term and the long term. Within the short term, yes, robotic partial nephrectomy is expensive compared to open partial nephrectomy, mainly because of the consumables and the up cost for getting the machine. And so for supplies and the utility of instruments, definitely robotic partial nephrectomy would be expensive. But the current hospital stay is usually between 1 to 2 days, and that is where a robotic partial nephrectomy could be beneficial. And with experience, once you reduce your OR time to less than or significant reduction, even if you reduce the OR time by 30 minutes, can prove to be cost effective. This is from the French healthcare system. I just took a slide out of that, and clearly they were able now, with the increased workload, published indicating that decreased OR time, reduced complications, and if you take away, reduce the number of instruments that you use, don't use hemostatic agents, then clearly robotics can be more cost effective. And if on the long term, you reduce intraoperative complications and avoid working in low volume centers, then robotic partial nephrectomy may prove to be more superior. Again, that is the other advantage of doing a partial nephrectomy, if you take into account the other benefits, is that by doing a partial nephrectomy, you reduce the risk of cardiovascular morbidity, dialysis, and you adopt more partial nephrectomies. Then certainly in the healthcare system, there will be a significant benefit on the long term in terms of reducing these complications and an impact on the healthcare system. And from that perspective, on the long term, one would feel that robotic partial nephrectomy could be more cost effective compared to open or laparoscopic. And more recent work is being looked at when people return back to work and then are more productive to the health, to the country's economy. That has never been logged into looking at whether this particular factor would lead robotics to be more cost effective on the long term. So yes, there are upfront costs, but down the stream, these advantages, as outlined here, would probably indicate that robotics may prove to be a new benchmark. Clearly, robotics has to be made more efficient. And how can we do that? There are challenges within the robotic ability, and that we have partly alluded to reducing the cost, and more importantly, doing complex renal tumors. If one starts getting more experience with robotics, can we carry on doing these complex tumors, central highlight tumors, predominantly endophytic tumors, or in tumors that are in ectopically fused kidneys that we already see, or tumors that are now T3A or T1 tumors coming up to 7 centimeters. Can these be managed robotically? And so to overcome this challenges, we have now started a program by which we have a careful preoperative surgical planning of certainly of these complex tumors with 3D reconstruction. And then, of course, there are other things available intraoperatively, which I will come down to, like intraoperative ultrasound, ICG. Can they help in carrying out these complex procedures? And then how can we improve the postoperative care? So here's a 2D image of a triple phase CT looking at a tumor, a very highlight tumor, upper pole tumor. Now to plan surgery, you want to understand the exact relationship of this tumor to the collecting system, to the main arterial supply, and to the venous anatomy. And so we have gone on to do a segmentation of these 2D images and convert them into a 3D image. And the same tumor now here, you can very clearly see that a large upper pole tumor, its relationship to the main, one of the branch blood vessels. You can subtract the venous anatomy and see more selectively which part of the tumor is being by which artery, its relationship to the collecting system and to venous anatomy, and gives you the confidence prior to surgery how well you're going to be planning your surgery, rather than getting in there and then facing the battlefield, so to speak. And in this particular case, you could dissect this artery and put a selective clamp, a hemalock here. It might help with hemostasis. So you could go on to do the same 3D reconstruction on other tumors. Here's another 3D reconstruction showing 4 renal arteries. And so you can plan surgery ahead, again, relationship of the tumor to the arteries and the collecting system. I've taken the venous anatomy out just to show more the renal artery branches. You can again see this particular tumor going very close to the collecting system. You can understand the collecting system and plan your surgery accordingly. And you can look at the renal bed, take the tumor out of this 3D reconstruction and see what your bed would look like and how you're going to plan your renorrhaphy. And not occlude the collecting system and the number of branches that you need to take on when planning intraoperative surgical procedure. And that takes away a lot of your mental cognition, so to speak, so that when you're in theater, you're more concentrating on the surgical part rather than thinking about where the structures are. So these images can also be overlaid onto the collecting system, onto the robot. And that particular central tumor here, we saw these veins that were going into the tumor. So we can plan this. We know exactly where this branches are feeding into the base of the tumor. And so you can plan your tumor excision very effectively and know where to place your clips, which vessels to ligate, when to excise, and then subsequently plan your renography. So you know the base of the tumor bed very clearly prior to getting into the operating room. So here's the two small venal veins that we saw on the 3D image. And again, it's just to demonstrate the internal renography, which I'm sure is a similar technique to open surgery. But again, then you know where your main blood vessels are, the depth of your renography that you need to take to avoid occluding the main renal vein. So we have the main defect is closed. Here's a horseshoe kidney, again, very important preoperative surgical planning. We've seen the tumor in the green part, and you've seen its relationship with the arterial circulation. Here's an interesting case, if I can open it up, that we did recently cross-ectopic kidney fused with the renal upper pole renal tumor getting into the IVC. Now, this requires very careful surgical planning. You want to do a heminephrectomy or a nephrectomy of the upper of the right side. That's the left kidney fused onto it. Here you can very clearly see the groove between the aorta and the IVC. Small tumor thrombus going into the IVC here, and you can rotate these images, and you can look at the back. You can turn front. You can look at you can see the depth of the tumor, its collection to the collecting system. You can then go on to look at the base of the tumor. I'll show that to you again. Yeah. So that's when the tumor is gone. This is where your renography is going to be. Here you're going to preserve the vessels. So this advanced 3D imaging really is the next tool. And certainly for even for smaller tumors in the upper pole, lower pole, anterior, posterior tumors, you can really understand the depth and the relationship of the tumor to your surrounding structures and plan surgery accordingly. So in this particular case, we were able to do this robotically, and let me put this thing back again. Yeah. So we were able to get into the aortocaval groove and ligate this renal artery, use the ICG, look at the perfusion, and did a heminephrectomy. And that's the kind of procedures one could carry on doing. With the help of the 3D imaging. So we looked at, can this 3D really influence surgical planning? And it's a paper we recently published, and yes, not surprisingly, yes, it did improve the perception of anatomy, increased the possibility of doing kidney sparing surgery, and really gave much understanding. More importantly, equally to the patient as well. If you show these images to the patient, they really understand the extent of the difficulty. And this was a paper we recently published, and we were able to show that, yeah, to some extent, it's a small study, that yes, 3D imaging will help. It will help patient education, and subsequently you can include them into training and simulation. And now currently we're hoping if we could run a multi-center study to see how 3D images can help with preoperative and intraoperative surgical planning. So the tools that we have for intraoperative is mainly to try and improve the vision, intraoperative vision, because most of it is in different shades of pink and red. So we could use Firefly to identify the renal vasculature, but now with the help of 3D imaging, and if really very rarely you need an ICG, then you can use an intraoperative Doppler ultrasound to identify. And the benefits of ICG are really to see if you've had complete ischemia, and then if you're particularly looking for selective clamping, as I alluded in the earlier case, we were able to identify the lower half of the kidney was well perfused. And then with differential perfusion, you can see the tumor doesn't light up, but the normal kidney will light up. And so when you're excising the tumor, you can see whether your base of the tumor is green. And let me see if this will play. This is, again, a partial nephrectomy done with the help of an ICG. And then if you look back, you can re-examine the base of the tumor as green. Is that really being used? Not yet. It's not been authorized by FDA, but again, because the reason being the dose that you give for differential perfusion has not been clearly worked out. Looking at this using an intraoperative ultrasound now is mandatory for partial nephrectomies. Here is a slide showing that the tumor would probably end up here, but putting an ultrasound, you can see there's a little hump further up. And that is where intraoperative ultrasound scan would be useful. One could combine the intraoperative ultrasound with 3D images. You could overlay it. Zishan, I'm not running over time, so just let me know. So we have now started putting these 3D images and looking at the arterial circulation and understanding the depth of the tumor, both with the help of the 3D imaging, the anatomy itself, the branches that are feeding the tumor, and then use it in conjunction with the robotic ultrasound to excise the tumor. So here we use the 3D image at the same time using the intraoperative ultrasound to mark the tumor, understand the depth. You can see the depth of the tumor here. And that gives you an insight during this section because you don't have a haptic feedback and every little thing helps. And because the anatomy is quite variable, sometimes you have a small tumor going into a small part of the renal vein. I don't have a slide here to show, but that can be easily picked up. And in order to reduce the risk of positive surgical margin, these three combinations, the 3D image and intraoperative ultrasound will help us to identify and hopefully reduce the positive margin rates. Now, more recently, we started enhanced recovery following partial nephrectomy. That is, the purpose is really to reduce the hospital stay from 2 days to 1 day and eventually to run a day case procedure. We've clearly shown with our ERS program, the length of stay is halved and over throughput is doubled. Readmission stay is low and absolutely high patient satisfaction. And these are things that will be used to measure cost effectiveness of robotics. Now, it may be that if you use ERS in a laparoscopic thing, you may still get the same benefit, but perhaps not the same. So these are clear advantages of the robotics. So some take-home messages. There's no doubt that a robotic partial nephrectomy has superior outcomes in terms of functional outcomes and effectiveness, and the oncological outcomes are similar. Hopefully with better surgical planning and post-operative, we might be able to make models that would be more cost-effective on the long term. And hopefully the robot might be able to take the golden spot. And as I alluded earlier, I just mentioned, there's a lot of work being carried out now on artificial intelligence supported robotics. And that's because we are now developing algorithms, database acquisition to the point that the robot AI programs can now recognize certain steps of certain procedures that can be carried out independent of the surgeon. And whether those will show better outcomes, that will remain to be seen. So clearly the human mind is going to be taken over by the computer, acquire data, images, informations, and already this thing is happening. And eventually the decision-making process will be taken away from us. That's in another 10, 20 years. And hopefully, I don't know whether that will be beneficial for us, but I think continuing integration with AI and computer technology is probably the way forward in ensuring better outcomes and perhaps increasing over efficiency throughput. So in summary, we can start doing what was necessary. We started with open partials, laparoscopic, and now we're doing things that are beyond, we never thought, certainly when I started my training. We have a very active charity program. We did the 10K run to raise money, clearly to improve our program. And here's the team just concluded raising £10,000 for the renal cancer research. And I'm currently running a fundraising event to develop a dedicated renal cancer research lab. They're all free, with the view to supporting the program of active surveillance, partial nephrectomy, understanding more biomarkers. And I think that is probably the way forward. What look like, as somebody alluded to earlier, we still don't know the way forward with renal cancer. And I hope in the years to come, we'll have a clear pathway. Thank you.
Thank you very much, Mr. Mumtaz. It was really good to know experience from one of the leading centers in the country. Any comments, please? Most welcome from colleagues here in Pakistan.
I was just, thanks for the talk. It was fantastic and a great insight to a large centre. I was just wondering what your experience with off-clamp or non-ischemic robotic partial nephrectomies was, and what patients or tumours you would potentially use that for.
So, I mean, clearly the data now, as long as you have a warm ischemia of under 20 minutes or 25 minutes, then there are no real benefits of having an off-clamp. So as a routine, we don't perform off-clamp partial nephrectomies unless it's a very small tumor, or like the case that we did with the crossed ectopic fused kidney, because we were able to ligate the main renal artery that was feeding the upper pole, but that's not off-clamp, I would say. Okay. Overall, I don't see any benefits of doing an off-clamp partial nephrectomy. And the blood loss is much higher. The risk of positive surgical margin could be much higher because your views are not that clear. So you really have to see at what point you will have a benefit of having an off-clamp. Yes, if they have a very poor EGFR and it's a single kidney, it's a small tumor, then one could say that you could consider an off-clamp technique.
Okay, thank you.
Thank you very much. Just a quick question, just for my own insight, just to ask my colleagues, senior colleagues in Pakistan, that I mean, I'm aware a lot of some of the centers have acquired robotic technology, and minimally invasive laparoscopic surgery is on the rise as well. So what is the current trend for, let's say, T1 cancers generally? Are we mostly doing partial nephrectomies back home, or is it still more trend towards radical nephrectomy, minimally invasive technique?
You're asking from colleagues in Pakistan?
Yes, Professor Mumtaz, please. if you.
Right. Okay. Can I come in here? I've been doing some work in Pakistan on this subject, and I think there are selected centers who are offering this service, especially in PKLI, Lahore. I have personally done a few partial nephrectomies, some open, some laparoscopic. And I think in context of the last question, we have done a few of these tumors with using clampless technique for the peripherally located tumors up to 3.5 centimeters in size, which does seem to work quite well. And I think it was wonderful to see cutting edge technology in Faz's presentation. And I think one can easily see that the future is going to only get better as these technologies progress. On the, just one further note on, I think it does appear there's a new technology is becoming increasingly expensive. However, for colleagues in Pakistan and Africa, I think there is hope in alternate technologies also being developed, which are going to be many times cheaper. One example is the FlexDex, which I have personally used in a few cases, which it's a laparoscopic instrument that gives you the robotic capability of instrumentation within the cavity. So I think these things are being developed, and there is a lot of hope even for countries who have limited financial capabilities and centers which, I think where there is a will, there will be a way.
Absolutely. Thank you very much, Mr. Chaudhary.
Zishan, just one comment following on from Asim.
Please.
I think FlexDex does have a future. I think if you combine it with the 3D imaging, which again is not very expensive, it is very helpful. Particularly, I mean, I use it in my pelvic endometriosis cases, and it is really exceptionally helpful, although it's mostly ablative. But FlexDex and the 3D is very effective.
Great. Yeah, thank you very much.
Sean, I think the most important thing is to develop an attitude that, you know, A, that we can treat these patients without sacrificing the kidneys, and B, develop a trend towards subspecialization, because I still feel, I travel a lot to Pakistan, that we have not developed that attitude of referring the patient to someone else who probably has more insight or interest, and they can do a better job for the interest of the patient. So that is what I think PAUS should focus on, that they should try to encourage people to subspecialize, designate some centers where they can, for example, Pardeep's presentation was brilliant. And if you want to do that kind of work in our country, then you have to just specify and point out which centers in the country would possibly could do this. So there is a lot of potential. There's a robot in Karachi which could be used for whatever work. Faiz have gone, I have gone. The robotic program has kicked off. They've done about 700-800 cases. But unless we focus on the best, you know, the patient best interest, that, you know, we are going to do partial nephrectomies. This is not a case where I can't do it and therefore I don't want to refer and just take the whole kidney out. So there is a potential, the lot of expertise in UK, for example. All of you can go and help to develop these subspecialist areas. And inshallah, you know, looking forward, I think we can make progress. When there is will, there is a way.
Yes, absolutely. Thank you. Thank you very much. So I think Professor Khan's message is that if it is a case, 7 centimeter, 6, 7 centimeter tumor where a partial could be done, irrespective of technology, even if it's open, then that should be preferred over a radical nephrectomy, even if laparoscopic expertise are there, because partial would offer nephron preservation and long-term reduced morbidity without compromising the oncologically. Yeah. Thank you very much. Right, so so this concludes our non-metastatic arm of the program. So we'll just move on to Dr. Shazina Aslam from Backford, who has been really kind with the timings and all, and is with us to talk about metastatic kidney cancer, both the current systemic treatment as well as role of cytoreductive nephrectomy. Please, Shazina, please, on to you. Thank you.
Thank you, Zishan. Can you see my screen?
Yes, absolutely. Thank you.
Great. So thank you for inviting me to talk today. It's a real pleasure. And it's been really interesting also hearing about what you all do as surgeons, because as an oncologist, I don't really get to hear very much about that, apart from our MDTs, of course. Without further ado, I'll move on to my talk, which is about the role of cytoreductive nephrectomy in the current era of systemic treatment for metastatic renal cell cancer. So the majority of renal cancers are clear cell tumours, and we all know that between 15 to 30% of patients will present with metastatic disease. But also there's quite a significant number of patients with localized disease who go on to develop metastatic disease as well after initial nephrectomy. Renal cell cancers account for 5% of all cancers in men and 3% of all cancers in women, so a significant number. And renal cell cancers account for quite a majority of renal masses. They're often picked up as incidental findings now in the current era of imaging for various other things. So more than 60% of renal cell cancers are now detected incidentally rather than symptomatically from hematuria. The prognosis for metastatic disease, however, still remains really poor, with less than 10% survival at 5 years. And that's always been a real issue with kidney cancer, that compared to other cancers, treatments have been lacking in terms of systemic treatments to try and get on top of disease and trying to improve survival as well as quality of life. So for metastatic disease, there's been various models that have looked at risk stratification, and the most well-known of these was the Memorial Sloan Kettering risk stratification model from Motza. And this is just really a reminder of this, because I think it's always good to be reminded. So this looked at 5 factors initially, which were the performance status, hemoglobin, time from diagnosis to treatment, the corrected calcium level, and the LDH level, and stratified patients into the favourable, intermediate, or poor prognostic group. And this graph just illustrates how patients did depending on which group they're in when they were treated with interferon, and it also shows that median survival changed quite drastically depending on whether you're in the favourable group or if a patient was in the poor group, ranging from 20 months in the favourable group to only 4 months in the poor risk factor group. More recently, there's the International Metastatic Renal Cell Cancer Database Consortium risk stratification model, which added in platelets and neutrophils to the criteria that were looked at and took away the LDH. And looking at that, if patients were grouped into the favourable, intermediate, or unfavourable risk group, their median overall survival varied quite drastically as well. So the role of cytoreductive nephrectomy. So in 2001, there were 2 randomized controlled trials, the SWOG and the EORTC, which showed prolonged survival if patients had an initial nephrectomy compared to immunotherapy with interferon alone. And this wasn't just related to their response to interferon. It was shown to be far more significant than that. Prior to 2001, there had been reports of spontaneous regression of metastases in some cases in patients who'd had nephrectomies, but these were the first 2 phase 3 randomized controlled trials that showed some evidence of a difference, although the difference was quite small. So with the SWOG study, it was a 3-month survival benefit, and with the EORTC study, it was a 10-month survival benefit. However, cytoreductive nephrectomy, as you all know, is not without risk, and patients with metastatic cancer, especially metastatic renal cell cancer, often have major morbidities and an increased risk of mortality, not only due to their metastatic disease, but other comorbidities. So they can have increased cachexia because of their metastatic disease. They could become anemic. They have an increased risk of coagulopathy, and they have paraneoplastic syndromes as well. The other concern with a cytoreductive nephrectomy is if they have significant metastatic disease, is that whilst they're recovering from their surgery, that could lead to a potential delay in systemic therapy and could affect their outcomes, including their survival. Okay. Can you still see my screen? Is it showing up as a slideshow?
Cytoreductive nephrectomy is slide we are showing.
Okay, great. So the current issues are that obviously initially everything was looked at in the era of interferon, and interferon, although it was a reasonable treatment for patients with metastatic renal cell cancer, their outcomes were still very poor and they had a lot of toxicities, and it was only patients who were reasonably fit and well who had any sort of response to interferon with a meaningful quality of life. However, so lots of other targets were looked at for kidney cancer, as standard chemotherapies didn't really work. And since 2005, the treatment options have rapidly expanded. And over the last few years, they seem to be expanding on a monthly basis, really. So since 2005, more therapies were introduced, which targeted molecular mechanisms underlying the carcinogenesis of renal cancer, and inhibitors of vascular endothelial growth factor receptor tyrosine kinase inhibitors such as sunitinib and pazopanib and monoclonal antibody bevacizumab became standardized first-line treatment options for favorable and intermediate risk metastatic renal cell carcinoma. And the mTOR inhibitor temsirolimus as well as everolimus became recommended for the poorer prognostic risk factor group. Several agents are now available, including immune checkpoint inhibitor, PD-L1 ligand receptor inhibitors, such as nivolumab and pembrolizumab, but also there have been many drugs that have been investigated and have shown benefit for metastatic renal cell cancer and have improved outcomes and prognosis for some patients, but not all. So I'm just trying to move it to the next slide, but I seem to be stuck. There you go. So the question now is, what's the potential role of surgery in metastatic renal cell carcinoma with the advent of all these newer drugs? So we're talking about cytoreductive nephrectomy in this talk, but obviously there are other surgical interventions that definitely help patients. So currently we think about cytoreductive nephrectomy in patients who are good performance status, who have resectable disease and have the majority of disease within their kidney, and then those patients could have a cytoreductive nephrectomy followed by systemic treatment. There is the potential for patients who have more bulky disease or bulky metastases or locally advanced or potentially unresectable disease to consider consolidative nephrectomy after systemic treatment, and also with patients who respond well to systemic treatment and have very limited metastatic disease or slow growing metastatic disease, there is also the potential to have their metastatic disease resected. Okay, so I don't know why that's jumping. Okay, so the question is, what's the role of cytoreductive nephrectomy in the current targeted therapy era? So there were two trials that have been done recently that were looking to answer this question, and they were the Carmina and the Certime trials. The Carmina trial looked at the role of nephrectomy in patients who had metastatic renal cell cancer, clear cell cancer, who were going to be treated with sunitinib, which is a tyrosine kinase inhibitor. And this trial was opened in 2009, and it randomized patients to surgery plus sunitinib versus sunitinib alone. And more than 79 centers who took part in this study, but recruitment was very slow. 450 patients were enrolled from September 2009 until 2017, so over 8 years. And there was a planned interim analysis at 50.9 months, so almost 51 months with median follow-up, and there had been 326 deaths observed at this point in time. And the result in the targeted therapy group alone was non-inferior to surgery versus surgery plus targeted therapy. So that's regarding overall survival. The stratified hazard ratio for death was 0.89, and median overall survival was 18.4 months in the sunitinib alone group versus 13.9 months in the combination group of the surgery and the targeted therapy. there was no significant difference in response rate or progression-free survival. This table just illustrates the outcomes from the Carmina trial, showing specifically that partial response was very similar in both groups, and that the objective response rate was very similar in both groups. The clinical benefit, which was defined as disease control beyond 12 weeks, was slightly better in the sunitinib alone group, but the trial wasn't really powered to look for this as a primary outcome. So the conclusions from the Carmina trial were that the sunitinib alone was not inferior to nephrectomy followed by sunitinib in patients with metastatic renal cell carcinoma who were classified as intermediate or poor risk disease. There were a lot of limitations to this trial and a lot of criticisms of this trial. One of the limitations being that patients enrolled into the trial were candidates who were appropriate for surgery in the opinion of their treating urologist. So the results aren't generally applicable to all patients, especially patients with a poor performance status or patients with minimal primary tumour burden or high volumes of metastatic disease, because all of these groups would not be considered for primary nephrectomy. The other thing to note is that this was a non-inferiority trial, so the results may well underestimate the benefit of cytoreductive nephrectomy. The trial went on for 8 years, but it only recruited 450 patients, and it was statistically powered to accrue 576 patients. It was stopped very soon after that interim analysis because of the slow and poor accrual. The other trial that's been done in recent times looking at tyrosine kinase inhibitors and surgery is the CERTIME trial, which was looking at the timing of surgery in addition to the tyrosine kinase inhibitor sunitinib. And patients were randomized to either upfront nephrectomy followed by sunitinib or sunitinib followed by nephrectomy after treatment, systemic treatment. And this trial, again, had a very difficult time in terms of trying to accrue patients. And over a period of 4 years, it managed to accrue 99 patients. It did show a longer overall survival with the deferred nephrectomy versus initial nephrectomy, but it was underpowered because of the poor recruitment. So it's underpowered for the survival and the primary endpoint of overall survival. So the learning points from these two trials are that the results showed that we shouldn't abandon cytoreductive nephrectomy in patients who are suitable for a nephrectomy if they have low volume metastatic disease, if they've got a good performance status, if they're favourable risk, or who have been candidates for initial observation. It's important to also note that both trials recruited patients with high median metastatic volumes. So in the Carmina trial, 42% of the total tumour burden were for patients who needed, so these were patients who really need to start systemic treatment, so that also needs to be taken into account when considering the data from both of these trials. So the latest treatment options for metastatic renal cancer have changed in the last 18 months. So now we use combination immunotherapy, so nivolumab as well as ipilimumab, which is a CTLA-4 inhibitor, use it in first-line treatment for metastatic disease because there's significant overall survival benefits with a hazard ratio of 0.66 compared to sunitinib alone. A lot of patients do tolerate the combinations very well, although I appreciate that these combinations may not be available in a lot of countries. The data is out there to show that there is benefit, and it may be that over time that these drugs become more sort of cost effective and cheaper, especially when they're off patent. So the other thing to note with immunotherapy, especially with combination immunotherapy, is that there's a small percentage of people who benefit and go into long-term remission. So although they're not cured, they seem to be doing extremely well and surviving well over 5 years, and some patients even getting up to sort of 10 years survival with little in the way of toxicity, so a better quality of life, as well as sort of hope for the future, really. So the ipilimumab-nivolumab combination also had a better patient-reported outcomes compared to sunitinib. So their toxicities were, that just shows that toxicities from a patient perspective were reasonable. Now, very recently, what's been looked at is immunotherapy with tyrosine kinase inhibitors as combination therapy. So pembrolizumab, which is an immunotherapy, which is a PD-L1 inhibitor, with tyrosine kinase, which is axitinib. So looking at that combination, there was a Keynote 426 trial, which has had some interim reporting after 12.8 months, showing a significant benefit in terms of overall survival, as well as progression-free survival for the combination of pembrolizumab and axitinib compared to sunitinib alone. There's also randomized trials looking at other combinations of immunotherapy and tyrosine kinase inhibitor, as well as monoclonal antibodies such as bevacizumab with immunotherapy. They've shown progression-free survival benefits, but final overall survival data are awaited, and they haven't been approved in Europe as yet because of further data being awaited. The ESMO guidelines, however, were updated in February of this year because of pembrolizumab and axitinib showing significant benefit. And they showed significant benefit in all prognostic groups, so in the favourable as well as the poor prognostic group, which was significant. The combination of ipilimumab and nivolumab should still be considered first line for intermediate and poor risk disease, and tyrosine kinase inhibitors also remain a very reasonable treatment to give to patients who have metastatic renal cell cancer, because they're more easily available and probably a bit more cost effective than immunotherapy. There's limited data for treatment after progression with these newer combinations of treatment, however, but tyrosine kinase inhibitors would be recommended as treatment for patients alone, or tyrosine kinase inhibitors alone would be recommended for patients who'd had this combination until further data is available. So this is just to illustrate what the ESMO guidelines tell us in terms of what to use for metastatic renal cell carcinoma at the moment for the good, intermediate and poor risk groups. And it just really illustrates that there's a huge range of treatments that we can now use for patients, first line followed by second line treatment. So that then leaves us in a quandary as to what we should be doing now when we've got all these combination treatments. Where does surgery fit in? So this is just to summarize that in the cytokine era, when interferon was around, cytoreductive nephrectomy was recommended in patients with a good performance status. But there's been 2 randomized trials that have looked at cytoreductive nephrectomy in the era of tyrosine kinase inhibitors. And whilst CERTIME was underpowered, Carmina did show that upfront cytoreductive nephrectomy shouldn't be considered as the standard of care for intermediate or poor risk patients with asymptomatic primary tumours, when medical treatment, so systemic anti-cancer therapy upfront, would probably be more suitable for these patients. Upfront surgery is also associated with morbidity and mortality, which could delay treatment, delay their systemic treatment. Secondary cytoreductive nephrectomy in patients with local symptoms due to primary due to the primary tumour or near completely systemic therapy remain a potential treatment option, however. So, surgery with cytoreductive nephrectomy is currently recommended in a select group of patients with a good performance status, but not for intermediate or poor risk patients with asymptomatic primary tumours when systemic anti-cancer therapy is required. First-line treatment is now immunotherapy, tyrosine kinase inhibitor combination, or an immunotherapy doublet. There's no data or evidence to show the role of surgery or sequencing in the advent of this combination therapy. More trials are needed to provide evidence for the best management and also the best sequencing, but there have been issues with accrual, and so that's also a question to bring up. How do we improve accrual if we do consider more trials? And the other question is, how do we identify the subgroup who would benefit from cytoreductive nephrectomy up front or surgery of any type? Because obviously there are some patients who will do very well with this, but it's really hard to identify exactly who they are despite the prognostic risk stratification that we have available. And that's the end of my talk. Thank you.
Thank you very much, Shazina, for a very thorough, comprehensive review. Any questions for Shazina, please?
Yeah, this is Dr. Saeed Akhtar from Pakistan. Excellent presentation, Shazina. I have a question for you. Do we still have any important biological markers like P53 expression, RB1, or any other new markers that may give us some hint into what will respond or what would not respond?
That's a really good question. And so there's lots of data, but there's lots of confusing data. So even with immunotherapy, where for other tumours, PD-L1 would tell you that immunotherapy would be the best treatment to go ahead with if you have high PD-L1 expression on the tumour. That isn't the case with kidney tumours. So although there's lots of markers that are shown on certain tumours, at the moment it doesn't necessarily fit with that this treatment will be best for this tumour. And also the thing to say is with metastatic tumours, quite often you will get a variable response. So in the metastases, they might respond and the primary tumour may not respond, and that might be due to heterogeneity of the tumour. The other concern is that as time goes by, the tumours may also change and evolve. So it's a really good question, but it's very, very hard to answer because at the moment there's still a lot of ongoing research as to what would be best. Yeah, personalised medicine for the future would be excellent if we can get there for kidney cancer.
Thank you.
Thank you very much. So I think the message, Shazina, is that for cytoreductive, low-risk disease, yes, then cytoreductive, the patient is fit, and but not for intermediate anymore, as before Carmina results we were, some centers were practicing.
Yeah, correct.
Okay, and just moving on from the same question, if let's say if we are working in an environment where, I mean, systemic treatment may not be advocated, or if the patient is not able to tolerate that, for an intermediate risk disease, would it still be worth, I mean, this is the general question to other colleagues as well, would we still advocate cytoreductive, at least in that scenario?
So I think it needs to be taken on an individual patient basis, doesn't it? It's really what's going to help them. And if they can't, if they're not going to tolerate systemic treatment, we know that cytoreductive nephrectomy can have a significant response for some patients and can help them symptomatically as well as with their quality of life. So it's definitely worthwhile considering, with me not being a surgeon.
Okay, thank you very much. Yes, absolutely.
I think if I may reply to that, I think in that scenario, the nephrectomy is just to palliate. And if the patient is symptomatic and you think that he can withstand surgery, you just do that and you make it clear to the patient that is a palliative operation is not going to improve his survival. Just reduce his suffering, I think.
Great. Thank you very much, Mr. Bose. Now, I'm really aware of the time, but before we quickly we move on to the next talk, we'll, for a couple of minutes, if everybody allows, just travel to West Africa, where my colleague, Dr. Madina Doe is there, who has been involved in training there, workshops we have done in laparoscopy. So just wanted to quickly ask, Medina, what exactly are the trends of presentation in Senegal? I mean, do you see patients kidney cancers a lot in early stages, small tumors, or is it mostly advanced as we have been seeing during the workshops?
Thank you, Dushan. The sound was not clear, but I guess you asked the stage of our renal tumor here in Senegal. Of course, mainly our patients come at very late stage. That makes the renal cancer disease in Africa quite different of what happens usually in Europe, because where patients in Europe have mean age like 50 or 60, here in Africa, patients come with a late stage disease, but at a very early age, like 20 or 30 years old. So that makes the two diseases very different. And also we have a lot of very aggressive tumor, which are already metastatic or locally advanced cases when we saw them. That's why most of the time we do cytoreductive nephrectomy, and we have the chance to be able to do palliative treatment for free for the patient, and we have a small series of patients on sunitinib after cytoreductive nephrectomy. So my experience about the treatment of the medical treatment of these cases is there are a lot of side effects with the treatment that make patients to be very uncomfortable with the treatment, but we see that all other symptoms like pain or hematuria resolve in this treatment, which is very good. So hopefully we are seeing more and more cases of tumor at an early stages, and sometimes even we can do partial nephrectomy. And you can testify here that we had done the little cases by laparoscopy, and we hope that we'll have more and more cases like that. Thank you for this great meeting today. We really appreciate it.
Well, thank you for attending. Yeah, clearly we remember on both workshops we had 3 to 4 centimeter tumors. Fantastic. Thank you. That was Medina. Hopefully she'll be with us around about this time next year for a fellowship. And now moving on to the last talk of the day. Catherine Dewar is with us, our cancer specialist nurse, as well as doing a lot of benign work. And last year we have one of my very dear colleagues from Ethiopia who visited us and was really liked the concept of a specialist nursing. Clearly, it's not a concept not in every healthcare environment. And even in Britain, some centers have more and some centers have less number of specialist nursing. So Kate will speak to us about support which a specialist nurse will offer when it comes to cancer diagnosis, especially renal cancer in context of today's talk. Kate, on to you, please. Great. Kate, are you still with us?
Oh, sorry, I thought I'd unmuted there. Sorry.
Great. So, Kate, I have to open your talk, isn't it?
Yes, that would be great.
Okay,
Thank you,
great,
Zisha.
fine. Just give me a second, please.
Certainly.
Okay, great. Right, so share screen. Okay, can we see Kate's talk now?
Yes, I can see it. Thank you.
Okay, great, fine. So go for it, please.
Next.
Okay.
So yeah, as I say, I'm Kate Dewar, one of the urology specialist nurses at Nine Wells Hospital. Up to now, I have been looking at benign work and also bladder cancer superficial, doing flexible cystoscopies as well. So now I have joined Zishan in the role of the renal cancer specialist nurse also. So with the clinical specialist nurse, the Scottish Cancer Strategy 2016 recognises that more people are surviving cancer for 1, 5 and 10 years. So the aims of the clinical nurse specialist is for people with cancer and their families to feel involved in the decision making. This is hopefully going to give a radical improvement in their experience and their quality of life, including the end of life, and a more equitable access to services and treatment. So our ambition is that all cancer patients will have access to a specialist nurse. Thank you, Zishan.
Okay, great, yeah.
Okay. So the clinical specialist nurse. So we act as a key worker across the whole care pathway of our patients. We have the ability to assess the patient's holistic needs, and we have holistic needs assessment tools to do this. We show empathy for the patients and their families. We try to give excellent decision making with our abilities and knowledge, and show in-depth knowledge of the tumour area within the kidney and what we're dealing with at that point in time. Thank you, Zishan.
Yep.
So my role as a CNS in renal cancer is, along with Zishan, to attend the initial consultation in the clinic with the patient. That way then hopefully I can provide further opportunity for the patient and any family members to further support them in understanding their diagnosis and their further treatment pathway. We support the patient's understanding with resources that we have. We have pathways that we can give them, and we're working on further ones at present. And we also have Macmillan Renal Cancer information booklets that we give away to the patients when they go. And with that, they also get my name and my contact number if they need to contact me as well. I'm hopefully acting as an accessible professional to them, coordinating their patient journey along with Zishan. Thank you. I would hope to be able to utilise the knowledge and experience to support the wider team in the community and also in the acute wards. So when the patient's in the ward, I can support the staff in the ward with the patient's care, but also in the community, access to myself from any district nurses or anybody that needs my support. Also a resource to support the post-surgery care and the development of treatment pathways, as I've said, which we are developing or have developed very recently within the unit, and ensure that the patient is on the correct pathway of care, and it's all in place for discharge with the follow-up plan for that specific patient, having undergone a specific procedure. Thank you, Zishan. No, wrong way. Oh yeah. No, that's fine. Sorry. So I will then attend the multidisciplinary team meeting to find out the final pathology and grade and hear the discussion around what we said about this patient's follow-up. We would then review the patient via Near Me, which, as we're doing just now, or telephone consultation, and advise the follow-up plan, which will include imaging and bloods. I can then do a holistic needs assessment and identify the patient's needs and concerns, which is then individualised. It's important in identifying other concerns, such as financial, exercise, relationship concerns, and then I can hopefully signpost them on to where they best get the support that they need in that respect. I would certainly hope that I can work collaboratively with Zishan to ensure the patient's safety, which is our primary concern there. Okay. So the impact of the key nurse-led activities is to improve the quality and experience of care for that patient, increase the productivity and efficiency for the patient, reinforce safety within the department, within the ward areas for the patient, and hopefully demonstrate leadership within that area also. Thank you, Sishan.
Great.
And thank you very much, everybody. And this is a view from the beach down south where I live, but not almost.
Most of the presenters live near to the beach. Thank you very much, Kate. It was
thank you.
Listening to you and your role in the urology care. Any questions for Kate? Great, fantastic. Fine.
Can
Thank you
I
very
ask
much.
something?
Please,
Okay.
please, Mazhar.
Hi, Kate. It's Mazhar. It's an excellent presentation. Thanks very much for highlighting the role of our urology nurses as a key worker, especially sharing your experience to our overseas colleague that you guys are amazing contributor to the patient care, not from the clinician side, but from the holistic approach. Just wanted to ask you, what is you guys over this current environment of pandemic crisis we're all facing, regarding the urology cancer nurse specialist role? Are you modifying your role, especially for the follow-up of cancer patients, or what is the plan? Is there anything that you're focusing on?
I don't think, sorry, thank you. I don't think we have modified our role too much. We have been continuing doing quite a bit of surgery, especially within 9 Wells. And we've still been active with our cancer patients. So yeah, we haven't modified.
Regarding follow-up, my point was regarding the follow-up. The patients who are on the follow-up regime at the moment, who have nephrectomy, say, so are you regarding, is there any like key worker or cancer nurse specialist-less follow-up that you are evolving or working on it?
I think you mean more toward telephonic follow-up, whether there's any modification.
Yes, exactly.
Okay.
Have you worked on any follow-up plan strategies?
Yeah, I think we would probably do more telephone reviews and also near me, so video linking with patients. That is certainly going to be much more our way forward from now on. Yeah, I think that's going to be key in the future. Yeah.
Thanks. Thank you, Josie.
Fine.
Thanks, Kate.
Thank you very much. Thanks, Mazhar. So I would just request my colleague, Mr. Asim Chaudhary, just to conclude the meeting and just any briefing points. But before that, I would just like to thank everyone, all the panelists, presenters, especially Mr. Asim Chaudhary himself and Professor Mumtaz for helping to organize this, and all the participants who have made it. Please, Asim bhai, on to you.
Thank you very much. I think all of us who joined in today have enjoyed and really benefited from the session that we had. And it's great to see people coming together from different parts of the world. And I just need to make 1 or 2 comments that I think the learning and teaching activity should continue under all circumstances. And I think the COVID did come in the way for the last few months and everything seemed to come to a halt. But Allah subhanahu wa ta'ala has created more ways, and Zoom came into being and became popular, and we've seen today how effective it can be in continuing with the very important role that we have of continuing to learn and to teach. And I think that is what we saw today. It was an excellent example of collaboration across the globe, and I think we must continue with this. And special thanks to Professor Mumtaz for supporting it. And inshallah, we intend to continue. I'm sure most of us will agree that this is an activity with particularly so during the COVID time, and I think beyond that as well, because it has created a forum or a possibility of an international interaction, which we all can benefit from. So I would support and propose that we have this program regularly every 6 weeks or so. and select one topic. And if anyone has any burning comments to make before we close, I think we'll welcome that.
I think it is. This is Dr. Saeed Akhtar from Pakistan. I congratulate everybody. I think it was an excellent forum, Asim and Zishan and Mumtaz. Thank you so much for your great efforts, and all the speakers were great. I think the fact remains that renal cell carcinoma specifically is a bad tumor. We don't have a good chemo. We don't have good radiation results. So surgery remains the mainstay, and early diagnosis remains the mainstay. But then there will be cases which will be coming late, and we have to deal with them. I think again, I've said this multiple times. Our challenge for all these cancers is try to understand their biological behavior. The whole crux of our effort with cancer is to understand the biology and treat the biology. And there's a lot of heterogeneity. In one tumor, there are different types of behaviors. We're learning more about bladder cancer, prostate cancer, and kidney cancer. And I think this multidisciplinary approach that we had today with the surgeon, nurse, oncologist, I think that's the name of the game. And I really want to congratulate all of the participants for giving their great input, surgeons, physicians, and nurses alike. Thank you so much. God bless you guys.
Thank you very much, Dr. Akhtar. Thank you very much.
Asim, Assalamu alaikum.
Please.
Asim, Assalamu alaikum. Dr. Atauriman from Shaw.
Wa alaikum assalam. Good to see you.
I think, yes, Assalamu alaikum. I think it was a very nice and excellent session. And as you said, in COVID, I think I really enjoy webinars, and it has been going on for quite some time. And I think it is very important that we continue with this, particularly in Pakistan, and postgraduate, and we as a consultant needs such support, particularly from our colleagues like you guys there in UK. And we need to develop system, particularly in Pakistan, as a system here is not as it is in the Europe or remaining world. Everybody is practicing everything. There are very few centers which focuses on subspecialization. I think this is a time where we need to subspecialize on different organs like kidneys, prostate cancer. And I think we need to continue this. And particularly this specialist nurse focus. And I think we need to focus on that in Pakistan as well. So my request would be to continue such webinars, which would be, one thing is, as you said, global connection with each other. And secondly, to educate ourselves. And we know where the future lies. So I would congratulate all the speakers, particularly Professor Mumtaz, Zishan efforts, and particularly your efforts, So if you want us to play some role, certainly we are here to help, and certainly we would continue to collaborate in any way you like. Thank you very much, Asim. It's a great effort.
Thank you.
Well, Asim, can I just add also, brilliant, thoroughly enjoyed the webinar, great effort, you beat us to it, and I was thinking of it, and then you come up with some brilliant idea. But the only point I'd like to add, perhaps with the support of Professor Mumtaz, to get a few more speakers from Pakistan as well, so that we can collaborate more effectively and have their perspective, and to see how we gauge over collaboration as well, because that's the most important thing. So hopefully with the next webinar, we have a few more speakers from Pakistan as well, so that we understand their perspective and see how we can collaborate.
Great. Yeah. Yes, I think excellent idea.
Yeah, definitely. I think it's just that that's what me and Asim bhai were.
Sure. No, I appreciate it.
No, absolutely. But we just said, let's do this experimentation webinar, which is more successful than as anything. So definitely, Ms. Mumtaz, this is the way forward. Absolutely. And Asim bhai, please.
I think with that, we and with the dua that may Allah subhanahu wa ta'ala put khair in it and make it easy for us going forwards, and keep us all safe in the current COVID times. And inshallah, we'll continue with these webinars and we'll notify accordingly. And with that, I think we say goodbye to everyone. And thank you very much once again. Jazakallah khair.
Great. Thank you. Very quickly, as soon as I work out about the video for these recording, I'll send it by email. Thank you very much. Thanks a lot. Allah Hafiz. Bye.